I'm Carly Taylor, one of the planning committee members for the wellness workshops. Thank you so much for joining this morning and logging into our Zoom webinar. We are capturing attendance this way, so we appreciate it. You can use the chat feature or raise your hand to ask questions throughout the duration of the training this morning. And again, please also share in the chat box your name, title, and the organization that you're here with. So it's so good to see everyone this morning. Thank you for joining. Happy Friday. We made it through the week. There's a couple of housekeeping items, things agenda this morning, so we're going to move on to that in just a moment, just to clarify a few things before we get officially started. So once again, good morning. Thank you all for being here. Please be aware that this session will be recorded and made available through the website and social media links to inform and educate on this topic. Therefore, keep in mind, if you choose to participate in an identifiable way, you acknowledge that your name and/or video will be recorded and you are authorizing the use of your information in the recording as described. You are under no obligation to speak during the course of the recording today. Just a quick note about copyright again. The recording of today's workshop is protected by copyright law and is not to be copied. I'm Carly Taylor, one of the planning committee for the wellness workshops. The wellness workshop began 10 years ago to support mental health professionals and community members in Denton whom work with children, youth, and families. As the wellness workshops have grown, we have begun to support mental health professionals throughout North Texas and beyond. Cook Children's Center for Community Health launched the Thriving Communities Collaborative in 2023, which brought together community partners with the same goal of improving children's health in North Texas. This group focuses on mental health, caregiver support, healthy lifestyle, and asthma. For more information on the resources and education that is provided by the Center for Community Health, please visit the website. We have many people to thank for working collaboratively as part of this to put this event together. We'd like to thank members of the Wellness Workshop Planning Committee, Cook Children's for providing CEUs, and you. If you have attended our previous event, providing feedback. We plan this program with you in mind. We'd also like to thank each of our speakers for giving their time and sharing their expertise with us today. With their permission, we will post the slides and video from today on the Center for Community Health website for ongoing use. As a reminder, you can find past webinars on the Center for Community Health and are able to earn CEUs for some of those also. We will put the link for this in the chat. So let me do that really quickly. If you did not receive the meeting packet with the presenter slides, you can also find that at the link just placed in this chat. Once on the website, you will navigate to the mental health tab and then find today's presentation and click on download PDF. A few other quick housekeeping notes. I will be hosting the workshop today along with Emily Russell, a program coordinator at the Center for Community Health. We invite you to engage with the speakers in the chat box, using the Q&A feature, or by raising your hand. You can talk with the group as a whole or one-on-one by clicking on the button next to the To field in the chat feature. This is located just above where you type your message. We will have time for questions throughout the presentation. You can use the Q&A box to ask your question. If you'd like to speak live, you can raise your hand and we can unmute you for you to speak directly. On the agenda this morning, we are providing an orientation into anxiety disorders, and then we'll discuss practical applications and treatment through case studies with generalized anxiety disorders, OCD phobias, separation anxiety, and social anxiety. We do not have scheduled break times during our time together, but we will pause periodically to take questions. Please feel free to take a break during this time or when you may need to step away for a few moments. By attending today's workshop, you will define diagnostic criteria for generalized anxiety disorders, OCD, phobias, separation anxiety, and social anxiety. Describe case studies with symptoms of a variety of anxiety disorders, and be able to identify at least 2 interventions to use with generalized anxiety disorder, OCD phobias, separation anxiety, and social anxiety. Importantly, an evaluation link for today's event will be shared at the end of the program. All are encouraged to complete the evaluation, and it is required to receive the continuing education. Today's speakers have no conflicts of interest to report regarding today's presentation. So without further ado, I am now very pleased to introduce our first speaker, Dr. Lisa Elliott. Dr. Elliott is a licensed psychologist, neuropsychologist, and clinic manager for Cook Children's Behavioral Health Clinic in Denton. She also serves as an on-site postdoctoral fellowship supervisor. Dr. Elliott earned her PhD from the University of North Texas in 1989. Dr. Elliott specializes in psychological testing as well as psychotherapy. Areas of specialty include depression and mood disorders, anxiety, trauma, learning disabilities, autism spectrum disorders, neurodevelopmental and neurocognitive disorders. She has served as the chair for the Wellness Alliance for Total Children's Health, led by Cook Children's Center for Children's Health, for 4 years. She has also served as the chair of the United Way Denton County Behavioral Health Leadership Team, as well as serving as co-chair for the DCB HLT Child and Family Work Group. Thank you again this morning. If you will please join the applause and a warm welcome. We'll get started with Dr. Lisa Elliott. Thanks so much.
I'm so excited to be back here again. It's been a while, but I've got to be very honest with you. I'm going to be a speed demon today, and the reason why is I have to leave at 10 o'clock to go to a funeral, and I deeply apologize. But my wonderful, wonderful, wonderful Dr. Amanda Smith is going to be able to answer all the questions. So I won't be in the question and answer portion because I'm going to have to bolt. And but anyway, she will cover for you, and she will be amazing. So these are the objectives. Like I said, I'm going to be a speed demon. I'm going to cover the demographics and trends with regard to generalized anxiety disorders, but anxiety kind of in general. We'll talk about the diagnostic criteria for GAD. We're going to talk about how it might present in kids and teens, differential diagnosis, and then treatment options, and of course, a case study. So the trends, we'll move to this as fast as possible. This was the CDC results back from the years of 2016 through 2019. If you'll notice, and we're just going to focus on the on the anxiety. For 3 to 5 years old, it was about 2%. For 6 to 11-year-olds, it was about 6%. And it was about 11% for 12 to 17-year-olds. This is the demographics as terms of this schedule from CDC that was published for 20 to 21. So I'm going to show you how that breaks down. Whoops, I'm going way too fast on this. I'm going to have to get a hold of myself. For anxiety, it went up to 2.2%, but for children 3 to 5. For children 6 to 11, it went up to 8%, so that's from 6%. For children or teens from 12 to 17 years, it went up to 15% from 11%. And I can guarantee you, I wish I could see a show of hands, but I think we would all agree it's probably higher than that now for anxiety, particularly for our ages 6 all the way to 17. At least that's what we're seeing clinically. The other demographics and trends that we see is there's often co-occurring disorders. 3 to 4 will have depression with anxiety. 1 in 3 will have anxiety, but they'll also have behavior disorders. And 1 in 3 children with anxiety will also exhibit some symptoms of depression. We all know that it went up to 20.5% worldwide for youth during the pandemic, but I don't know if it's that high currently, but I would say that we're very close to that still. 1 in 5 youth have anxiety symptoms. Girls are more likely to be diagnosed with an anxiety disorder. Median age of onset is about 11 years of age, and it is oftentimes the earliest of developing pathologies. But we can see a strong overlap with depression. And I'm anxious to talk about how the similarities of all of this demographic ties into the case presentation I have for you. So, diagnostic criteria. I am sure all of you are familiar with this. This is straight from the DSM. So we know that excessive anxiety or to diagnose it, we've got to have excessive anxiety or worry more days than not for at least 6 months, and it's got to impact several areas of activities or their life functioning. It's very difficult for the individual to control that anxiety or worry, and it has to be associated with 3 or more of the following symptoms, except for children, it only has to be 1. And that includes restlessness or feeling very tense and keyed up on edge, they have a lot of fatigue and being easily fatigued, difficulty concentrating or their mind going blank, irritability, muscle tension, sleep disturbance, such as difficulty falling asleep or staying asleep. The other criteria is that that overall worry and anxiety, as well as the physical symptoms, have to cause distress or impairment in multiple areas of their life. It could be social functioning, academic functioning, occupational, or just other important areas, even like withdrawal from activities they've enjoyed in the past. The disturbance is not associated with any kind of physiological effects of a substance or medical condition, and it's not explained by some other medical condition. And when you look in the DSM, it's very specific that we have to look at differential diagnosing. So again, that not due to some kind of medical condition or any kind of substance use, but we have to look at how it differentiates between social anxiety, separation anxiety, panic attacks, OCD, PTSD, or other adjustment disorders, as well as like in depression, bipolar, DMD, and psychotic disorders, which is what's going to be great for you to hear from both Dr. Smith and Becky, but also our other presenters, just because, and Dr. Johnson, because what you'll see is the differential diagnoses with this. So what does it look like and how does it present in our kids and teens? Well, there are a lot of words that are used to describe anxiety, and a lot of them are interrelated, but there are distinct differences, and there's also distinct different emotional responses. So fear is one thing that's talked about at times. So what we need to think about with fear is that it relates to a known or understood threat. So there's going to be an emotional response to that perceived or imminent threat or danger. Now, stress, that's mental and physical symptoms such as fatigue, irritability, anger, sleep disturbances, muscle tension, headaches, to any kind of stress-provoking situation. I don't know about y'all, but I may be feeling a little bit of that right now, just making sure I get through all of this fast. So then we have worry. So worry has more to do with just overall mental distress or thoughts that we kind of maintain in our head all the time. And it's usually associated with like some kind of anticipated or impending situation. It may also include overthinking. And then we have anxiety, and that can be oftentimes associated with like the anticipation of a future event or like a persistent or excessive worries that don't always go away when the stressor has been removed. So I want to talk about normal worry versus an anxiety disorder. This is like associated with generalized anxiety. So the difference between normal worry and an anxiety disorder is severity. Also, anxiety is considered a disorder when that child is worrying, what they're worrying about impacts their overall functioning. And then if a child is feeling highly anxious, it's a natural reaction to a stressful event or a dangerous event, but it goes from normal worry to an anxiety disorder if the anxiety is out of proportion, if it persists, and it interferes with their daily life and overall healthy development. And also when worry becomes the child's automatic, and when I say child, I'm also meaning teen, when a child becomes their automatic response in many situations, and they're constantly feeling that keyed up um, feeling, and like reassurance and coaching them and giving them tools doesn't actually help, like if parents give them tools. And also when anxiety and worry prevents them from participating in life events. So I'm going to do just a quick example. I just had a diagnostic interview this week of a child who has, as a neuropsychologist, I see a lot of this, but they have a 22q11, which has also been associated with DeGeorge syndrome. And this individual has had normal stressors associated that with their developmental delays and academics challenges and social functioning. But they've had a major life event that occurred this past spring where the parents are going to have an impending divorce. So all of a sudden, this child who normally did not have behavioral disruption and dysregulation and rages started exhibiting that. But in addition to that, she's completely withdrawn from all of these other activities that she enjoyed, such as ninja warriors, gymnastics, and is no longer wanting to engage with friends. So obviously that prompted this parent, the mother, to seek treatment, and which was a very, very smart decision. So that's like an example of normal worry versus what when we need to pursue for an anxiety disorder. This is a great pictogram, which all of you can find on the internet, that I like looking at it. I will frequently use these pictograms for my psychoeducation process, both with the child or my patient as well as with parents. But anxiety has this normal reaction to a stress or difficult times. It's triggered by a specific stressor. It has a start and ending point. It can be also very helpful and motivational, particularly like taking tests. It lessens significantly or may disappear once the stressful situation's disappeared. Relaxing can oftentimes help make you feel better, and it can be a response to a toxic situation. Versus an anxiety disorder often can come out of nowhere. There's a strong, intense, disproportionate emotional response. It can be ongoing, lasting for weeks or months. It interferes with their day-to-day life experiences. You have a lot of physical manifestations with this, trembling, headaches, heart rate. We'll review that multiple times during my presentation. And then it also feels impossible to control, which is exactly why this mom prompted a diagnostic interview. Um, this is a great tool. I use this a lot in helping, particularly our older elementary kids and also adolescents. So what we often think anxiety looks like, this is what we use to help them identify what they're actually feeling below. So negative thinking, like that glass is half empty, the Eeyore thinking, that's what I call it, the Eeyore mindset. They push people away and they want to be alone, that hopelessness, and they want to give up easily. Lots of worrying. They worry about all situations, but they oftentimes worry about what others think of them. They need things to be in their place. There's lots of inflexibility. So the rigid thought processes, they can be very intolerant of others and very intolerant of changes and uncertainty. You're going to see a lot of somatic complaints, the stomach aches and headaches, as well as just overall general aches and pains. Trouble sleeping, difficulty falling asleep, staying asleep, nightmares. But also what you'll see is they're not wanting to sleep alone anymore, particularly with their younger ones. Anger and frustration, feeling agitated, lots of anger, low frustration tolerance. I call the word gritchy, that combination of grumpy and witchy, that feeling. The direct defiance and challenging behavior. They may need lots of reassurance, lots of clingy behavior. We see an increase in like difficulty with staying focused, like lack of attention, as well as distractibility. Avoidance behaviors. This includes the school, the friends, and events. So the example I just gave to you earlier. Dysregulated, another one of her behaviors, where she has difficulty controlling behaviors, a lot of crying, acting out, difficulty managing emotions. They have a strong need for control, not only just for controlling events, but also controlling others, including play activities and in situations. And then there's oftentimes high expectations of not only themselves, but also others. And so there's a lot of perfectionistic behaviors. This is a very good tool. I will print this off and we will go through identifying how their anxiety is demonstrated. Another tool is what I'm going to show you next. It's the iceberg. I'm sure all of you have seen this and look at this. So we talk about the behavior that's exhibited, and then we talk about, and I have them identify the feelings below that derive that behavior. And so a lot of times kids will understand these, but we'll also look at other behaviors and we'll write in. I will print this off and they'll write in what they think their anxiety looks like, but then also the feelings that they're experiencing. And then if there's other ones, we'll write this down. And then this is oftentimes what we share with the parents. Now, chandeliering is a term that kids may not always know, so I explain it. I'm sure all of you probably have heard of it. It was a term coined by Brene Brown. That chandeliering is what they call when a seemingly calm person, someone who manages things very well, suddenly flies off the handle, really for no reason. So in reality, what they've done is they've pushed down all of these anxious feelings, possibly even hurt feelings for quite a while. And then when a very innocent comment or event occurs, they suddenly go straight through the chandelier. That's how she came up with the chandeliering term. So this could be generally a pretty calm child who just suddenly has a full-blown temper tantrum. So that's what I mean. So these are great tools for the psychoeducation piece. I use them all the time. They're available on the internet. Print them off. You can use them too. Now, differential diagnosing. So this is going to be like one of my key points, and it's going to be very well demonstrated in the case presentation. I strongly encourage psychological testing. And when I talk about psychological testing, I don't mean just where we just give checklists for like anxieties or depression, but we have to look at objective measures as well as projectives. But psychological testing is critical, and you're going to see how it plays into the case that I'm presenting. So, what is differential diagnosing? It's really a systematic approach to ruling out all the possible diagnoses that could be explaining that child's or that patient's symptoms. It's like making you into a detective where you're looking at the clinical history, their behavior, not only what you observe, but what other people report, assessments, and all the collateral information. So an accurate diagnosis is so important because what it does, it ensures effective treatment. So the diagnosis informs and creates the treatment plan, and then from there, it will help direct you to evidence-based treatment approaches. A misdiagnosis can lead to ineffective treatment. For example, if we diagnose ADHD when it's really anxiety, what we may be doing is looking at relaxation and teaching relaxation techniques when really what they need is more executive function, addressing those kinds of tools and strategies. Also, if we confuse autism with OCD, we may be teaching exposure and response prevention, which will do nothing but accelerate the anxiety or distress for someone who's on the autism spectrum. So that's why it's critical to have an accurate diagnosis, because it does inform and direct your treatment. But another advantage of differential diagnosis is it helps identify any co-occurring and comorbid diagnoses. Oftentimes there's overlapping symptoms, and so it's going to be important for us to look at both the primary and the secondary diagnoses, because that's what helps develop a comprehensive treatment plan. Then the last one is it helps us to rule out any kind of medical conditions or other social or environmental conditions that may be impacting it, because that's also part of what we need to look at to help with the overall treatment. Medical conditions that I frequently see that oftentimes drive or impact a lot of the anxiety is things like thyroid disorders, seizure disorders, concussion. So it's absolutely critical for us to look at the holistic picture to drive a very good treatment plan for them. The other thing we need to do is look at medication side effects as well as substance abuse, if that applies. So I'm going to look at some of this and to help explain what I mean by this. So severe anxiety is unrealistic. An example of what that would be is after having sex, a girl may worry that she may become pregnant, but a girl with an OCD disorder might worry that she's pregnant even though she's never had sex. Severe anxiety is also out of proportion. So a high school sophomore may stress over the SAT, taking the SAT, which would be normal, but a boy with a generalized anxiety disorder might stay awake at night worrying about the same test even though they're just in fifth grade. Severe anxiety is being overly self-conscious. A boy might feel nervous about talking to girls in class, which would be normal, but someone with a social anxiety disorder might avoid ordering in a restaurant because they're afraid of humiliating themselves. Severe anxiety is often unwanted and uncontrollable. A kindergartner may cry at school because they miss their mom, But a boy with a separation disorder might cry at school because he can't stop thinking that his mother will die if he's away from her. Severe anxiety doesn't go away. While anxiety symptoms are common and even expected after a disturbing experience, such as a car accident, over time, most children and adolescents will bounce back from them. But 3 months later, a girl with a post traumatic disorder might still have nightmares and be unwilling to ride in a car. Severe anxiety oftentimes leads to avoidance. So a girl may be very nervous about going to a birthday party, but a girl with specific phobia of loud noises might refuse to go to birthday parties because they're afraid a balloon may pop. So those are some examples of how to help with the differentiating with that. Other guidelines with this is a young child who is overwhelmed by worries may not realize those worries are unrealistic or exaggerated, and they may not express them, but it will come out in their behavior. Also, children who have severe anxiety will oftentimes try to avoid the things that trigger that. And kids with generalized anxiety will worry incessantly about their ability to meet expectations. They tend to seek reassurance and attempt to soothe those fears. And oftentimes they can become very rigid and irritable. The stress they experience may lead to physical symptoms, like I mentioned previously, the fatigue, stomach aches, nausea, vomiting, sleeplessness, and headaches. But it's important to also monitor for crying jags, the temper tantrums, the clinginess, difficulty concentrating, irritability and anger, and that unrealistic thinking, that and catastrophic and pessimistic thinking and overthinking. Now, these are pictograms that are also available on the internet. I will frequently use these. These are very good for helping to demonstrate to parents and kids the differences and also the overlaps that we see. So oftentimes anxiety is confused with oppositionality. And I'm bringing this one up because this is going to apply to my case study that I'm going to present. But with anxiety, you see the excessive worry, the physical symptoms, and the avoidance. The ODD, you're going to see frequent temper tantrums and anger outbursts, the defiance and the refusal and deliberate attempts. But there is that overlap. And so that's why it's important to provide the differentiating diagnoses here. You see irritability and frustration in response to stress, but you also see difficulty managing emotions or impulsive reactions. Here is another great pictogram I will use, the anxiety, the ADHD versus the anxiety. So with ADHD, you have the poor management time, hyperactivity, forgetfulness, trouble completing tasks, difficulty following directions, and impulsivity. With anxiety, you're going to see excessive worry, the irritability, trouble sleeping, all the things I just mentioned before, but the overlap. You have to look at the fidgeting, inattention, distractibility, trouble organizing, procrastination, and inability to relax. Then another one that you need to look at is anxiety versus depression. Again, all these are available on the internet. They're very good for psychoeducation. The anxiety piece, excuse me, we have the worrying. I know I feel like I'm kind of like on a repeat button here, but the worry, the trembling, the nervousness, intrusive thoughts, fear, feeling, losing control, sleep problems. But let's look at depression, persistent sadness, feelings of hopelessness, loss of interest in favorite activities. You might also see that though with anxiety, isolation, self-harm or destructive thoughts, this excessive sleepiness, wanting to sleep all the time, and fatigue and worthlessness. But the overlap, agitation, physical symptoms, the frustration, the restlessness, the avoidance, and even appetite changes. So when we look at this overall, it's really important for generalized anxiety disorder to look at all the subtle signs. So I'm going to cover some of those. So the ones for emotional changes include looking for the irritability, the easy to agitate, that feeling of edginess. Like I said, my favorite word is gritchy, that combination of grumpy, witchy feeling. Restlessness, unexplained emotional outburst, whether it's or behavioral outburst, difficulty concentrating. You also have to look for the subtle changes in school performance, that significant drop in grades, missing assignments, poor test performance, even the unwillingness or desire to go to school. Look for the subtle signs and physical changes, the frequent headaches and migraines, increased complaints of aches and pains, gastro problems, including IBS, fatigue, overall just malaise, changes in eating habits, changes in their sleeping habits, the difficulty falling asleep, staying asleep, not feeling rested, not wanting to sleep alone, and the nightmares. But then also look for panic symptoms, difficulty breathing, chest pains, the rapid heartbeat, dizziness, sweating and trembling, the numbness, feelings like they're going crazy, feeling that they're going to die. All of those are subtle signs. Now, I always like to cover a little bit, just briefly, that there are negative consequences if we don't look at anxiety, consider anxiety, and treat anxiety. And what we've seen is that oftentimes untreated anxiety will lead to the increased risk of depression, but there's also an increased risk of substance abuse disorders. So we know that addressing anxiety can help mitigate that. We also will see more academic challenges as well as failures because of the lack of attention and concentration, the failure to complete assignments, to turn things in. We will also see the school avoidance. We will also see increased social challenges and isolation where they're avoiding school, avoiding their friends, dropping out of preferred activities that they've enjoyed before. It's not uncommon to see increased physical symptoms. And as they stay longer, then it's more of a problem because we do know that chronic stress impacts brain functioning, particularly from a neuropsych standpoint. We will see a lot more brain fog. So it's important to address that. The other thing too, we'll see more panic disorders or these unrealistic fears, and they kind of overwhelm them and can take over their thought processes. And when I'm seeing a lot, and I'm sure a lot of you are as well, is this inability to launch. These kids that are anxious, they will not engage in normal developmental adulting behaviors like finding a job, learning to drive, applying for college. In May of 2024, I had 4 high school kids that had refused to learn to drive. They would refuse to follow through on the things I'm planning for their future in terms of finding a job or actually I'm applying for college. So I'm seeing an increase in that. So it's really important that we address that. But then if we leave it also unaddressed, we may see increased risk of suicide. It tends to be more rare, but increased anxiety leads to increased depression, which will lead to increased suicidal thoughts and self-harm. So it's really important that we do not dismiss anxiety and that we treat it. So what are treatment options for this? The best steps, of course, is to always encourage parents to make an appointment with their physician. I strongly encourage seeking out a psychological evaluation so you've got solid differential diagnosing and just recommendations for effective treatment. And we've looked at the whole picture, a holistic picture. We've got to provide and guide families on this and parents in how to support their child and their teenager. And if these anxiety symptoms are impacting them in a school environment, then it's critical that we help them and encourage them to set up a 504 or IEP plan, establish appointments with their school counselors, um, if even social skills group and lunch buddies. I just presented earlier this week to all of the Denton ISD school counselors, and they are right there on board with that. They love to help, they want to help, so encouraging that engagement in school is critical. So evidence-based treatment, what is it? Well, we know that parent self-help can be the very first line of treatment for our young children. Parents need to be involved. So our preferred therapy approaches are to involve the family in this. When I'm working with a kid, I let them choose. Do you want your parents involved the whole time? Even if they choose not to have them in, we always have to wrap up with the parent because therapy does not occur in a vacuum. And these parents need to know what our goals are, what we're working on, and how to implement that in the home base. We also know that cognitive behavior therapy, and I'm sure I am preaching to the choir, has got the best evidence-based outcome treatments for anxiety and depression. So we work a lot on those skills. We also teach mindfulness-based strategies, acceptance, commitment, therapy, as well as mindfulness tools. Medication is absolutely critical to consider. And then in the process of preparing for this presentation, I found something really cool that I'm going to share with you in a little bit, but it's called SPACE. It stands for Supportive Parenting for Anxious Childhood emotions. It's a really cool program. I want to explore it more. I know I talked to Dr. Amanda Smith about it. She wants to too. So I'll share a little bit about that, but that's another really good evidence-based program. So treatment for kids and adolescents. We have to first look, there's obviously three treatment modalities. It's therapy and medication and the combination of both. So we know that mild to moderate anxiety, it may be appropriate to start with just therapy. But we know that if it's moderate to severe anxiety, it's much better to use a combination of the both. And if we see school refusal, that it maybe we need to look at partial hospitalization for that. Whoops, I went too fast. So cognitive behavior therapy, I, I'm not going to talk about this much because I think everyone's aware of it. It is how we change our perceptions. It's got the best outcome research to support it. But basically, what we think and what we do impacts how we feel. So we have to change those perceptions. So that the process of looking at identifying those distorted thoughts, how we replace them with what is truth and what is real, what is accurate, what is logical, helps impact their overall change. Oops, man, my fingers are going fast. I apologize. Okay, then we have acceptance and commitment therapy, which is really nothing but a variation or subtype of cognitive behavior therapy. But the premise of this is it focuses on the individual thoughts and feelings and how they're affected by events and other people around them. And so the goal is to increase their tolerance for emotional pain, especially how to avoid painful events, but really focus on teaching them coping strategies to relate to that emotional pain and giving them tools. And that's how they work on changing their thoughts and their feelings. Then DBT, that is another variation of CBT. Its main goals are to teach people how to live in the moment, how to develop healthy ways to cope with stress and regulate those emotions and improve their relationships. So, what they do is they address destructive or disturbing thoughts and behaviors while incorporating all of the treatment strategies, such as teaching emotional regulation and using mindfulness tools. I know all of us have been trained on DBT here, but also we've been trained in EMDR. But all of these tools are very, very effective, and it's oftentimes it's best to use combinations and tools from each one and make it more individualized for each one of our kiddos. Now, this one's a space one. So, supportive parenting for anxious children. This was actually a treatment program that's developed out of Yale University by Dr. Lebowitz. And it's usually done in small groups and limited sessions. But what it does is it focuses on teaching parents tools to help their child overcome like high anxiety, so generalized anxiety disorder, OCD, and any kind of related problems. And so what they do is they learn how to increase the supportive communication at the same time decreasing accommodations in a healthy way. So then the child then improves their daily functioning and maintaining healthy boundaries. And I encourage you all to look at it because you could actually get trained in this, but it was a very cool program. Other programs that we look at is the Cool Kids Anxiety Program. This is both for kids that go from 7 to 17 as well as parents. It's a program that teaches children and their parents how to manage their anxiety. It can be done individually or in groups, and it involves the engagement of both of them. But it teaches practical skills. One that I use a lot is the Coping Cat. And so it is from 6 to 17, but it's a cognitive behavioral therapy intervention that teaches kids how to recognize their feelings, label them correctly, analyze it, and then they develop strategies to cope with those anxious feelings. But there's a really cool Coping Cat workbook that is used for 8 to 13 years of age. And then the CAT project workbook is used for those 14 to 17 years. And so they've adjusted those workbooks so it's developmentally appropriate with examples and pictures. Now, the BRAVE program is one that I've not used, but I've heard lots about it. It's more of an interactive online program that looks both at prevention and intervention for youth anxiety, and parents and kids participate in it. It's about 4 to 10 sessions, depending upon their age level. And it focuses on cognitive behavior therapy, and it also teaches the parents about how to handle things. And then, of course, the last kind of treatment for this is, and I need to pay attention to my time, is anxiety medication. So this is actually came from a slide from one of our physicians. So SSRIs, which is selective serotonin reuptake inhibitors, is the first line of defense. Sertraline is frequently used. Actually, it's used a lot for anxiety. It can also be used for depression, OCD, and it's recommended for 6 years and up. So that's Zoloft. Fluoxetine, which is Prozac, is used frequently for depression, OCD, affected with kids with on the spectrum, selective mutism, and it's recommended for children 7 years and up. Now, I'm going to butcher this name, so I'm just going to go straight on into Lexapro. That's the name for it, but the generic name is whatever, Excaprolol something. But it's also used, I've seen it used frequently for anxiety and depression, as well as social anxiety, and it's for 10 years and up. And then we've got duloxetine, which is Cymbalta. Now, it's an SNRI, which means it's both a serotonin and norepinephrine reuptake inhibitor. It's very effective for generalized anxiety disorder, but also I've seen it used for depression, and it's for 10 years, ages and up. Now, I'm excited to get to the case study. I picked this one specifically because it follows exactly this about why it's important to do psychological testing, why it's important to have a really good differential diagnosis, and look at all comorbid diagnoses. So, this was a little 6-year-old when she came in to me. She was referred. Um, and what she was actually referred by her pediatrician, and she was referred because she had been in play therapy for a long time and there had been no progress whatsoever, and it was a multi-symptom presentation, so she was really referred for psychological testing. She had huge behavioral outbursts that would last for 30 minutes, includes spitting, screaming, biting, throwing things, wanting to punch holes in the wall. She had these behaviors only at home, never at school or in public at all. She was really mean to her siblings. At school, she was a model student. She was very kind of more agitated and easily irritated at home. She also they endorsed a lot of ADHD behaviors, but she also had a lot of worry about the NICS plans, wanting to control things, as well as medical procedures and storms. So, and her play therapist had diagnosed her with ODD. So this was in October 2019. We got our schedule in for testing. The testing was revealed. So we went through the testing, and the feedback was done at the very beginning before COVID, the very beginning of March 2020. And what the testing revealed was a very superior IQ. In fact, bordering more closer to that very superior range. And so she could easily become bored. She needed to have so one of the things that we strongly encouraged was for her to be involved in the gifted program. She needed lots of enrichment programs because that would, allow her to stay focused a little bit better. She also demonstrated some mild symptoms of inattention and impulsivity, but the testing revealed very, very significant symptoms of anxiety, and she had emerging features of depression. And she communicated herself that she had a lot of physiological symptoms of anxiety, as well as the need to control things in her environment. She had lots of distress with any kind of change whatsoever. There was huge fear with a negative social evaluation, which is why she never exhibited these behaviors in front of her friends or in school. And she also noted intense fears of tornadoes and tornado warning, the drills that were at school. So what we did is we were going to begin therapy, but obviously COVID happened. So then she started therapy in the fall of 2020, and it went all the way through the initial therapy through fall of 2021. So because of COVID, of course, that elevated that anxiety a lot about returning to school. She expressed a lot of worry thoughts, and she's very articulate. And so she was able to describe these things. So not only does she have a very high IQ, but she's got a high emotional IQ too. So she did a great job with CBT. So we established the goals with family. We built the rapport with her. We did a lot of psychoeducation and about with the parents, especially about their role and how to manage this at home. I worked with her on identifying coping strategies, and we spent a lot of time on psychoeducation. And I created a worry thermometer for her. So I wanted to show you what this looked like. I couldn't find the same one on the internet, but this one is out there, so you can find this one. But what we did for her is what we would do is she would talk about all how she felt. And what we did is that we put it in order of intensity. Like down here, it was low and worked up here. With her age, she loved the worry thermometer. And then over time, what we would do is we would create the tools that would work for her. And we used a lot of CBT tools and mindfulness tools. And so we would put those here. So then she had this at home so that she could reflect back on it and use this to help guide her, but then also her parents could too. So it was highly effective for them. And then she was, because she's like a high achiever, wants to please, she created a success tree poster for her bedroom. So she drew this tree, and what she did, she cut out leaves out of construction paper, and every time she had a worry and she conquered that worry, she would put the leaf on the tree. So it was a way for her to see visually her improvement, because her improvement increased her confidence in herself. So by the end of 2021, she was doing incredibly well. So we made the decision to terminate therapy at that time. Then she returned in fourth grade when she was 10 years old. And so she had increased levels of anxiety, but they were now being exhibited both at home and school. At home specifically, she had a huge increase in challenging behavior. She was a lot more disrespectful. Suddenly she was lying, and she had a lot of unkind behavior towards her siblings, her younger sisters. So once again, we used the CBD tools, and I used this here, the zones of regulation. I'm sure all of you have seen this, but this was one that we used specifically for her. And so what we did is we came up with the tools that would work for her. But I also taught her what I call Lisa's quick version of thought stopping. And I'm kind of wanting to make sure I rush through this so I can teach you that myself. So we'll cover that tool. But she did incredibly well, and until and then we terminated until 6 months later. So then at almost 11 years, in the summer 2024, again, we had this huge increase in severe behavior problems, very disrespectful, increased lying, screaming, very mean towards her younger siblings. But we were also seeing recent conflict with peers and her close friends. And she was able to verbalize that she had this increased anxiety. She felt a lot more pressure with school and responsibilities, particularly since she was in the gifted program. She had a lot of fear about disappointing her parents, even though they were not putting those expectations on her. She was very worried about performing well in her competitive dance. And parents were even looking at pulling her out of competitive dance because they felt like it was increasing, but that would create all kinds of issues for her. She didn't want that. What was great about her is she was able to say, I'm using my tools, but I can't make my brain from overthinking. And she also said, in quote, the calming tools do not seem to help me anymore. So parents and the patient, we discussed a referral to psychiatry. They started her on Zoloft. She had the most positive response to a only 12.5 milligrams. So low dose. Her psychiatrist started out very low, titrated it up though, but she had a change in 3 days, a huge change in 3 days just with 12.5 milligrams. So we spent a lot of time on psychoeducation with the parents and the patient regarding the anxiety, impact on family. She had huge remorse and regret about how it impacted her family. So we used tools to manage that at home. We continued the therapy over summer and early fall using the CBT tools. She felt like she could implement them well, and they were working again, and she was doing great. Then when she was in fifth grade, it was she was 11 and a half years old, we reinitiated therapy for specific concerns. Parents and patient reported increased impulsivity, both at home and school, a lot more challenges with executive function skills at home and school. She had a lot of difficulty with self-control. She had, again, increase in lying, challenges with selecting quality peer relationships. And what was interesting, this patient had a long history of very solid, healthy peer relationships. And here recently, she'd been choosing to socialize with kids at lunchtime and recess with peers who had phones. And she was not allowed to have a phone. And she was not hanging with her other friends who were not allowed to have phones. And these kids were actually encouraging her to break the rules, both at school and home. And she was getting in trouble. So what we did is we reviewed the past testing, noting that it had indicated there we needed to monitor for ADHD. And it's not uncommon for children who are incredibly bright to be able to mask ADHD symptoms until things get a lot more challenging and we have to manage a lot more issues or a lot more multitask a lot more with changes in classes and academic demands. So we reevaluated the testing. Sure enough, the ADHD's behaviors were markedly atypical, and so psychiatry then added a stimulant with, again, very positive reports. So time was spent on psychoeducation, talked about comorbid diagnoses, generalized anxiety disorder, and ADHD. We also implemented a 504 plan at school, which worked really well. We continued the CBT and mindfulness tools, as well as working on executive function tools and friendships and relationships. How do you identify who's a good friend? How do you identify how to be a good friend? And looking at the I call it the circle of friends. And we also worked online. Again, we had huge positive success with this, and we terminated therapy at the beginning of May. So the point with this case is looking at the value of differential diagnosing, looking at and developing a very effective treatment plan that looks at comorbid diagnoses, that looks at psychoeducation involving the school. Everything I've just talked about, this is a perfect case study of how you have to implement and tie in all of those. Now, let me see how I'm doing. Coping tools, am I doing okay? It is okay. I've got a few more minutes left, so I want to cover some tools. This is what I wanted to get to. My goodness, I feel like I am actually in a race. So let me grab a drink of water real quick. So, thought stopping tool. Now, this is CBT. This comes from CBT. This Lisa's version of what I've done is a quick tool. I call it thought stopping, but it actually involves 3 steps: thought stopping, thought replacement, thought reasoning, or otherwise known as logic. So what I teach the kids is that thought stopping is very quick. You're there for a split second. You have to yell stop in your head, or you can use a hairband and flip your wrist. Not from self-interest. I make that very, very clear, but it gives a quick response to like, I've got to think about something else and I need to immediately move in to thought replacement. Now, thought replacement is where they stay until they have become completely regulated. So breathing is in control, tension's released, their thoughts are under control, not racing. But what we do is we spend time identifying for each child what is a space of joy for them mentally and what is a space of peace or calm mentally. And so, and I want it to be very heavily sensory related. So I use an example for me. So a place of calm for me is I'm in a boat. I'm on the water. I feel the boat rocking. I hear the water lapping. I hear the birds. I'm hearing my 80s music. I can feel the warm sun. I can smell my suntan lotion. So I show them examples of how I load my brain up mentally with sensory things of experiences of what creates calm for me. Now, joy, I'm starting to smile just as I talk about my little slice of heaven on earth is I'm laying in bed and I've got both of my babies and I'm feeling their fat little chubby little legs. I can hear them and smell them. It just makes me happy. That's my joy. So then what we do is we go through that and we write down for them what are their times or memories that are sensory loaded that gives them great joy. What are the ones that give them great sense of calm? So then I encourage them, okay, you stay in this spot until you can regulate, because they cannot use logic or reasoning unless they're regulated. And we talk about how irrational thoughts sit here. We've got to get up here for rational thoughts. So once they're calm, then we go to step 3, which is the critical one. So what is your past history? What is truth and what is real? What resources or helpers do you have? And we always ask the question, will the world come to an end? So I'm going to demonstrate this with testing. So this is a real case, a real situation. So had a young lady this past spring who works very hard. She's got some learning disabilities, but she's an AB student. She works really hard. And she had actually, unfortunately, failed one time a year ago, one of her STAR components. I think it was math. And she was able to retake it in this or retake it. She got some in the school provided interventions for her. She retook it and she passed it. So she was coming up for this past STAR testing for this past spring. So of course she was highly anxious. So her space, her calm spot was the one that she enjoyed the most, and it was that she was at the beach. So I'm just going to give you that information. But what we talked about from the logic standpoint is we talked about what is her past history. Well, her past history is that she is an AB student. She's taken many, many tests. She has passed them. When she has failed a test, it did not prevent her from failing a class. And in fact, when she has failed the test, she was able to retake that test. She has failed portions of the STAR, but what she did is she's retaken it, so she's passed it. So that's her past history. She needs to know what that is. What is truth and what is real? When she was highly anxious about a test, she either passed it or she was allowed to retake it. And when she actually had the STAR test one that she had failed, she sought help. She had people who helped her, taught her the tools, and she passed it. And she never failed a grade. That was her fear. We talk about what resources and helpers does she have. She has her parents, she has all of her teachers who were concerned about her, and even her principal. So she knows she can rely on her helpers. She also had friends who were encouragers for her. And then we talked about, will the world come to an end if you fail a portion of a STAR test? And she discovered from real example, no, the world did not come to an end. And the bottom line is the world will never come to an end with any of the things that we worry about. Therefore, it's not worth worrying about. So that's how I use that tool. That's the thought stopping one. And I'll try to quickly get through the zones of regulation. Here's an example. You can find it on the internet. They're very helpful. I used it before with my case study. I showed you that. Okay. Other tips, we all know that mindfulness, distraction, and self-care are critical. I just love these things that Cooks has provided us that are for helping to control our breathing, that you run your finger on, you can actually feel them. It helps calm them down. Kids love these. I cannot stress that enough of how great that is. But we all know, and we talk about this all the time, is that in addition to quality sleep and quality food, not sugar, proteins, good fats, that the three things that we can do that can help control our things is by exercising, socializing, and then doing things for others. In fact, doing things for others creates more long-term effects for the positive neurotransmitters that we need to have. Here's another tool for feelings identification. Here's some deep breathing tools besides those ones I just showed you. We got the 5-finger, the belly breathing. All of those are tools for deep breathing. I'm trying to hurry. Calm down fidgets. This is one of my absolute favorites. Kids love this. This is also from Cooks, but I'm sure you've probably got a whole storage of calm down tools, but we use these a lot. Even when they're talking about it in therapy, it helps them. And then grounding tools. We all know the 5 things you see, 4 things you can touch, 3 things you can hear, 2 things you can smell, 1 thing you can taste. The yoga, there's great YouTube videos for kids about how to do the yoga, and you can do it in session. Of course, and then we also have journaling, the color journaling, writing, talking about their feelings, the worksheets. The Coping Cat workbook has got some great ones of those. Okay, and then also included are great resources. And oh my gosh, it's 10 o'clock. I've got to stop. Here's some great helpful resources, books, and then websites and apps that you can use, references. Thank you with questions. And I'm going to have to pass this off to my wonderful Dr. Amanda Smith. And I apologize for going so fast. So I will stop sharing. It's great to be here. Hope you all have a wonderful weekend. Amanda, thank you.
You're very welcome, Lisa. Thank you. Thank you so much, Dr. Elliott. Do we have any questions then for Dr. Smith? We'll take about 5 minutes to answer any of your questions. You can place your questions in the Q&A box in the chat, or raise your hand and we'll unmute you.
I agree. Lots of positive feedback on that. I think she did an excellent presentation and a great job, setting the rest of us up for success that are going to be talking today. So, yes.
I know we had a few questions a while back about if you're getting the slides, if you need that. They will be available. You can see the link that's in the chat, and then they'll also be available online on the Cook Children's website. Yep. Thanks, Carly, for adding that link.
I love how you're in the presentation, Emily. You look very nice.
Oh, I didn't know that was there. Okay. Any more questions? Any questions at all?
Just saving them all up for my presentation.
All right. Okay, well then let's go ahead and we'll jump in then, and I'll introduce you. So Dr. Smith, she's a native of North Carolina, where she received an undergraduate degree in sports medicine from Elon College and a master's degree in counselor education from East Carolina University. She worked as a school counselor for 6 years before moving to Texas to pursue a PhD in school psychology at Texas Women's University. Amanda completed her internship at Lake Dallas ISD, followed by a postdoctoral fellowship in neuropsychology at Cook Children's. She liked it there so much that she decided to stay and currently works as a licensed psychologist in the Denton Behavioral Health Outpatient Clinic, where she sees children and adolescents for psychological and neuropsychological evaluations and therapy. In her spare time, she enjoys traveling, camping, and spending time with her animals, a Great Pyrenees named Barley and 2 Siamese mixes named Azure and Toby. So thank you very much, Dr. Smith, and I'll turn the time over to you.
Okay, thank you so much, Emily. All right, let's see if I can.
Actually, Dr. Smith, before you jump in, there was one question that came in. And it was, can you speak about differentiating between trauma symptoms and ODD and anxiety?
I think we could do a whole presentation on that likely. But I mean, obviously you want to look at the child's history, and if there is trauma present, that would be an even bigger reason to do some psychological testing to really kind of tease that out. I mean, we often do see a lot of overlap with those emotional and behavioral reactions for kiddos that have been through trauma. I mean, that's part of the criteria for PTSD, is to be having like big out of proportion emotional responses, hypervigilance, and things of that nature. So yeah, I think doing a really good, thorough evaluation and assessment is going to be really helpful. And as far as the treatment, I mean, there is no, there's TBRI, and there's, approaches that we use, trauma-focused CBT, for kiddos and anyone that's been through trauma, but you're still going to be treating the symptoms. So if they're experiencing anxiety-like symptoms as a result of trauma, those types of interventions and approaches are still going to be helpful for them. So yeah, great question. Perfect. So kind of like Lisa, even though I don't have a commitment after this, I have a lot of material I want to cover in a short period of time. I was talking with my husband last night about this presentation, and he's like, well, most people have a hard time filling up 15 minutes of speaking. And I was like, oh, no. I feel like people who treat OCD tend to be very passionate and excited about it. So we always have lots to share and like to talk about it. So, and thank you, Emily, for that introduction. And just as a side note, on Sunday will mark my 10-year anniversary with Cooks. So I'm very excited to reach that milestone. I love it here. So anyway, I went too far. So we are going to be talking today about treating pediatric OCD and phobias. I really ended up focusing more on OCD, and you'll see why as we go through the presentation. With phobias, the treatment is exposure-based. With OCD, the gold standard treatment is exposure and response prevention. So we're essentially using exposure-based therapies with both of these populations. So, all right. So why do we have people that specialize in treating OCD? Why is that important? Well, for most people, the recent statistic is it takes 14 to 17 years after symptoms emerge to obtain effective treatment for OCD. So why is that? Well, again, differential diagnosis. If we don't pick up on OCD and we think it's generalized anxiety only, or maybe a behavioral issue, the therapies are not going to be as effective, just like Lisa was talking about. The formulating effective treatment plans. So that unfortunately happens to a lot of people where they're in therapy and maybe they're having trouble, articulating the symptoms, or the therapist doesn't pick up on it, or maybe they're not getting any treatment because they don't see it as impairing as it actually is for them. So there's also, a lack of specialized providers, especially for people, from lower income communities and households. So, at Cook's, one of our big things is to be accessible to lots of kids and families. So I love that I'm able to offer this service to kiddos who, don't have commercial insurance, and we can, help them as well. So. All right. So, what is OCD? Like, most generally, we have obsessions and compulsions. So, the obsessions are those unwanted, intrusive thoughts or images, urges. They trigger intensely distressing feelings. So, we all have those like weird, disturbing, odd thoughts that pop in our heads from time to time. The way that I explain it to my kiddos with OCD is like, it's almost like there's a river and everyone has a net. So, most of us, our net has holes that are big enough that, big worries or big problems get stuck in the net and we can address those. But the holes are big enough that kind of these like random weird things just sort of pass through, and we don't, like, we might notice them, but they don't get stuck. Well, people with OCD have much smaller holes in their nets. So all of those weird, unwanted, just disturbing like thoughts that pop in get stuck more so than individuals that don't have OCD. So then the flip side of that are the compulsions. And this is what distinguishes like OCD from anxiety, from phobias, those types of things, is that there's some sort of behavior that the individual engages in an attempt to like mitigate this, to like lessen the distress that's caused by these thoughts. And oftentimes they're not necessarily linked to like a logical consequence. So we'll go through some examples of this as we continue in the presentation. I do have a case study at the end that I'm excited to share, but there were so many I wanted to share. What I ended up doing was putting examples from other kids that I've worked with in some of my slides, so I may go off on some tangents from time to time, but I like examples in my presentations, so hopefully you do too. All right, and so I love this graphic that OCD is a cycle. So it starts with those obsessive, intrusive thoughts. And then, like any sort of thought issue, which is why CBT is really effective, that we attach meaning to it. And what I attach as a meaning to a thought is maybe different than what someone else attaches. And if I have a more like salient, intense reaction to that, it's going to cause distress. So for OCD, it can be anxiety. It can also be disgust. So there's lots of like disgust or discomfort obsessions that are in OCD. So then as a result of that, we go into like this compulsive behavior to alleviate our distress. For a short time, we're like, oh, okay, it's better. So now it's taught us, oh, I need to do that to feel better. But the thing is that short-term relief doesn't last, and it just comes back more intensely and stronger every time we engage in that compulsion. So as you see, we have this sort of like off ramp here of ERP, which exposure and response prevention is, like I said, the gold standard treatment for OCD. It works for a really high percentage of people with OCD, and we'll talk more about that in a minute. Right. So pediatric OCD is, the area I specialize in. So I wanted to kind of keep this topic like focused on that. So again, repetitive, distressing cognitive events. With kids, a lot of times we have some sensory responses, things just not feeling not just right, some discomfort. Again, that disgust can be a part of it too. So our response is with a distress relieving but functionally impairing behavior. So that's, classic OCD. We have distress over germs, so we engage in obsessive hand washing or compulsive hand washing to the point that our hands are dry and chapped and bleeding. It's taking up hours a day. We're using an excessive amount of soap that our family's having to buy and replace. So it's not a functional response. So again, associated with significant time, distress, or impairment. So we're looking at how much time are these behaviors taking up? How distressed is the person if they cannot engage in these behaviors? How impairing is it as far as, well, we've missed soccer practice 3 times this week because Bobby's shin guards don't feel just right and he keeps having to readjust them, and it's taking hours of time. So again, not in keeping with normal developmental phases. So in a bit, we'll talk more about, we engage in some kind of age appropriate sort of compulsions that are low level. Again, they don't reach this distress level of like OCD, but there are some things that kids do at various ages that could kind of look like some OCD stuff. And also level of insight is really a factor here too. How well can the person recognize that um, their compulsions or even that their obsessive thoughts are not realistic? I frequently work with kids that say, I know this isn't true, but like I just feel like this way. So that would be a person that has some pretty good insight. Um, Especially with younger kids, they may have some insight, but they may not have the words to describe it. So it takes a lot of digging. I have to ask lots and lots of questions. Does it feel like this or like something else? Like, can you describe what it feels like? What thought is happening in your head? What happens if you can't do the thing? What would that be like for you? So trying to like really drill down on, do they recognize this as problematic or not? And, what helps them and what doesn't help. So some common obsessions that we see in kiddos with OCD, a lot of contamination, worrying about harming their families, harming themselves, some kind of goes along with those aggressive themes. We see some sexual themes in kind of the same sorts of veins of either questioning their own sexuality or have I engaged in intercourse with someone like and they were unwilling and I didn't realize that, so those types of things where, very, very concerns about kind of sexual acts. And so a lot of scrupulosity, which is like a religious or moral themes, like have I made God mad? Have I sinned? So symmetry, so having to, line things up, making things feel just right. Like I said, the shin guards or like having to get our socks aligned, or if I touch something on one side, I need to touch it on the other. And then for kids especially, I see lots of like this needing to like confess or ask questions. So they'll engage in a lot of repetitive question asking, even when they know the answer. Mom, do you love me? Mom, are you mad? Is when are we going to that thing? And just asking kind of repeatedly can be some of the obsessions that I've seen. Some compulsions that go along with these, hand washing or cleaning, again, repeating. So doing things either a certain number of times or doing it until it feels right. Checking, did I turn the lights off? Touching things like we talked about, having to even things out or touching things in a certain order, having to arrange or order things. Hoarding is kind of a related compulsion to OCD, where it's hard to get rid of things. I've had several kids that I've worked with where they have a hard time getting rid of maybe old toys because, again, they say, I know this doesn't make sense, but it feels like I'm going to hurt their feelings. Like maybe this is a Toy Story situation, and they really, are going to be upset if I get rid of them. Avoiding, so avoidance is a compulsion we'll talk more about in a minute. And then mental compulsions is sort of a newer like thing in OCD where, people are recognizing more that not all compulsions are active physical things. Sometimes it's more of a mental process. So for example, like some rumination, like trying to figure things out, like compulsively, where it's not just like, oh, well, I wonder, but it's, like rehearsing, thinking things through, replaying things that happened previously. Again, avoidance of things that might trigger OCD, reviewing memories, and even kind of like questioning. There's a real event OCD where it's like, did that actually happen? I need to go back and research it. A lot of like thought diffusion stuff where we're trying to, oh, I had a bad thought. I need to counter that with a good thought. A lot of self-reassurance and then just overthinking of evaluating the meaning of thoughts can all be mental compulsions. So here's some examples from my practice. I worked with a kiddo that was changing outfits multiple times per day because of some contamination fears, excessive hand washing, avoiding or refusing to touch certain things. I have several kids that wouldn't touch doorknobs, and repeatedly telling parents, "I love you." Um, Chronic slowness is one that people don't often recognize can be OCD, but I worked with a kiddo where like that feeling of being rushed, like we have our routine we've got to do and it's on my timeline and you can't say, "Oh, we're running late, we got to go." Like that results in some really big like upset from that. Excessive concern about kind of right and wrong, sin, doing things that make other people upset, repetitive question asking we talked about before, over concern with numbers. So that could look like doing things a certain number of times or certain numbers being good or bad. Um, I've worked with lots of kids where even numbers are good, odd numbers are bad. So having to write odd numbers is very distressing. Some people that have some like scrupulosity tied to their OCD, the number six can be bad because 666 is like demonic and things like that. So just assigning value to numbers. And then for kids in particular, but it could be for any family member, roommate, like life partner. So trying to force others to act in a certain way or participate in rituals. So I work with one girl where she has some contamination fears and she wants her parents to clean her devices, but she wants them to wash their hands. Like she has to see them wash their hands first. So we worked on cutting that part of it out and just saying, "You're going to have to trust that my hands are clean if you want me to do this." So, like I mentioned before on insight with OCD, it definitely is a lot easier to work with kiddos and individuals with OCD when they have some insight. And in general, people like anyone can be affected by OCD, but I tend to see a lot of individuals who are more on the average to high average, like of intelligence side, and they're often just very like kind, good kids that I work with that would never dream of, intentionally like hurting anyone's feelings or doing anything wrong. So they get very distressed by these thoughts, and it's because it's very counter to what they believe and what their values are. So helping kids realize, hey, if that thought isn't what you truly believe, that's probably OCD, is really helpful. But I also rely on the kids I work with to be able to kind of tell me if they do something that they feel like is maybe OCD, because I will talk about some rating scales and some assessment tools that we have. But I'm a lot of times OCD kind of goes under the radar for people, unless someone really close to them notices these kind of odd or repetitive behaviors. So some examples, oftentimes it's like, "Hey, I've noticed I do this thing where," and then they'll tell me and I can either say like, "Yeah, that might be OCD," or like, "No, I think that's something else." But I worked with one girl where she felt like cars were following her when she was driving, so she just had to keep checking to see if they were there, which kind of sounds like it could be like borderline paranoia. So again, differential diagnosis is really important to be like, do you truly believe people are following you? And she's like, "No, I don't think they're like following me to get me. I just notice that they're there, and then I feel like I need to keep checking." Um, so very different than like a psychotic process, but people that don't know what questions to ask could definitely mistake some of these behaviors for something else. Um, yeah, I need to check my phone to make sure I didn't take any inappropriate pictures. I feel like I need to tell my mom every time I do something wrong, so that confessing. A kiddo, like I have to walk down the stairs a certain way, or else I have to go back and redo it. Um, or I get stuck on the toilet because I never feel like I've wiped enough. I never feel like I'm clean. Or I've had kids that can't get up because they're not sure if they're done using the toilet, and they just have this like lingering doubt. Okay, so some things that are not pediatric OCD. So it's not a transient phase, or it's not just perfectionism by itself. We talked about before, I mentioned there's some like normal age dependent behaviors, like in early childhood. There are lots of kids who want things done a certain way. They want it just so. Maybe, they have some bedtime fears, so they're doing these elaborate routines to help calm themselves and to feel better. But that's something like if it is persisting into later childhood and on up, it's like, okay, maybe this is something that's a little problematic. It's taking hours for parents to be able to get their kid to go to sleep. It's affecting them. That would be a point we would be like, let's look at this maybe as OCD. So in middle school, it's really popular to collect things, to have hobbies, have focused interests. Sometimes this is the first time where the kid is really kind of focused more on friendships than family, and they get really intense about friendships and relationships and things like that. Not OCD. And then finally, like some superstitious behaviors, especially in young children and athletes. So some of that can get pretty intense. We don't wash our socks until as long as we're winning in the playoffs and things like that. But it's not, again, when we go back to that, is it taking a substantial amount of time? Is it distressing? Is it like affecting their daily functioning? And for them, it's just related to this one thing, this one activity. And they have a level of knowledge of like, I know this probably isn't really changing the outcome. But yeah, some superstitious behavior can be normal. But again, all of these, it's like into a point, and then at what point do we decide? And that's why we have the diagnostic criteria that we have. And then other things that are not technically OCD but kind of get lumped in with OCD sometimes, or differential diagnosis is important. So other anxiety disorders, generalized anxiety, separation anxiety can have some flavors of OCD, but again, that obsession part is common in lots of anxiety disorders. It's the compulsion part that's tricky. Amenophobia, fear of vomiting, is one that's really common, and again, these can be treated with exposure. So if we say, oh, I thought it was OCD, but it's actually emetophobia, the treatment's going to be the same, so it's not as big a deal. And we'll talk about that in a minute. Autism, especially in younger children, because there is a lot of the restricted repetitive behaviors. So how do we distinguish that from OCD? Kind of an overly simplistic way that I think of it is usually with autism, kiddos that are engaging in repetitive behaviors, it makes them feel better. It's regulating for them. It's a positive experience. Typically with OCD, it's a negative experience. It's very upsetting. It's very, not necessarily things that they want to engage in. But again, young children have a hard time articulating the difference. So that's why assessment is really important. Some tic disorders are technically, that's not OCD, it's a related disorder. Eating disorders, ARFID, again, kind of can be exposure based, but it's important to distinguish between the two. Psychotic disorders, like I mentioned with that one girl talking about, our car is following me. I had a kiddo that would have to check his bed for like mini cameras, he told me. But he didn't, like, he recognized that they're probably not there. I don't feel like someone's like really watching me, but I just have this thought that I need to follow up on, and PTSD. All right, so comorbidities, there are lots, as Lisa mentioned earlier. So there is a really high co-occurring rate of OCD and other anxiety disorders, 31%. Mood disorders is also pretty prevalent at 17%. So other neurodevelopmental disorders, ADHD, autism, those types of things, 16%, and tic disorders, 12%. So there's a lot of overlap with this. And I was really impressed with this study. It had like 17,000 people in it, so a really good sample size to get this information. All right, so differential diagnosis. So I pulled a few of these to say, is this OCD or is this maybe something else? So you can either, if you want to type in the chat, you can. If you want to just kind of think to yourself, you can also. So like OCD or something else is our game here. All right, so the mother of a 3-year-old is concerned about some recent uncharacteristic behavior. He insists on lining up toy cars in straight lines. He'll not let different food types touch each other on his plate. Otherwise, he throws tantrums and becomes distraught. So do we think that's OCD, or could that maybe be like autism? That's kind of would be a definite rule out there to determine between the two of those. Then I would agree, not likely OCD. Yeah, more likely autism. Yes. That would be kind of my first thought, is like, that definitely sounds like autism. Again, we can't from this distinguish for sure, but we're not saying like, oh yeah, that sounds just like OCD. All right. Oops. Second one. So parents of an 8-year-old report that bedtimes, which used to be fine, are becoming impossible. The child insists that both parents are present, that they answer a series of questions in the exact way. If interrupted, she begins the process again, and this can last up to 2 hours. So do we think this is a developmentally appropriate response, or do we think this might be OCD? Think lots of OCDs. Yes. Possible OCD. Good. Yes, because that's kind of the tipping point, like that I mentioned, where the degree, like this is excessive. This isn't just like I want mom to come and read me a story and lay with me for 5 minutes and then I can go to bed. This is a little more severe than that, for sure. Good job. All right. This one cracks me up. After seeing a TV special on OCD, parents bring their 15-year-old daughter, who's an A student and enjoys playing on several sports teams in addition to sitting on the student government. She likes to spend 30 minutes nightly to organize herself for the next day. Do we think this is OCD or like a kid that's like just very organized and involved? Yeah, normal kid. Yeah. I'd say probably a little more with it than most kids. I don't know too many teenagers that organize themselves for the next day, but yes, absolutely. This does not sound like OCD. This sounds like a pretty typical kid. All right, and the last one, an 11-year-old presents with recent abrupt onset of hand washing 30 times a day, refusal to touch anything his brother has been in contact with. Are we thinking, yeah, maybe OCD, or it's hand washing 30 times a day? Yes, it's OCD. So yes, I think that kind of helps like determine what's normal developmental behaviors versus potentially OCD versus potentially autism. So I like kind of going through some of those. All right, so why does differential diagnosis matter? So kind of like I've alluded to before, it matters more when exposure-based treatments are not generally indicated. So things like borderline personality traits, bipolar disorder, most eating disorders, like schizophrenia, paraphilias, like exposure is not going to be in like a widely used treatment for that. However, other types of anxiety disorders, phobias, ARFID, and the obsessive compulsive related disorders, like body dysmorphic disorder, body focused repetitive behaviors, hoarding. So anytime we're using exposure, it's it's still important to distinguish, but less so when the treatment aligns. All right, so let's talk about themes of OCD. So they used to call them subtypes, but I like that they've moved to this term of themes because it really like rarely does a person say you have this subtype of OCD. There's like flavors from lots of different ones. So I think it makes it more unified and less like, well, you have that kind and I have that kind. It's just what's the flavor of the week kind of thing, because there can be lots of themes. So contamination is probably one of the most commonly known and thought about. But I did want to touch on emotional contamination, which I find really interesting. So this is kind of like vibes rubbing off on you, basically. Like you feel like if I'm around this person because they're negative, that's going to make me negative. And to some extent, yes, our mood is affected by the environment that we're in, but it's more again to that extreme degree. I can't be around my brother because he's dumb, and if I'm around him, I'm going to be dumb. Like those types of things where it's extreme. But other types, kind of pulling from some past kiddos I've worked with, obviously excessive hand washing or showering, refusing to touch or go near certain things or people, even their belongings. So again, it kind of is an extension of the person. So if I'm near their stuff or have to touch their stuff, I'm going to take on their characteristics. I worked with a girl that would go through before each meal and look at all the forks and had to pick out the cleanest fork, had to pick out the cleanest bowl, because she was worried about getting sick from it. I worked with a girl that anything other than water, she like would not be around it. She would not touch it. Like the thought was like, what if it gets in me or in my mouth? That would be disgusting. So even a matter of like holding a drink for a friend was a problem. So a lot of contamination fears there with her. That was a unique one. Some harm themes. So obsession about hurting yourself or hurting your family or your family being hurt, or just in general, kind of something terrible happening. The thoughts are often like, this is something terrible is going to happen. It's going to be my fault. I find this one is one where the obsessions and compulsions usually do not align very well. Like, I have to say goodnight to my parents or else they'll die. I can't look while I'm riding, or I have to look up while I'm riding in the car, or we will crash. So for these, it's a little like, oh, okay, that seems to not really go together. If I hold a knife, I'll stab a loved one, things like that. And then it results in, again, that reassurance seeking or avoiding doing certain things. And then it just kind of contributes to that same cycle. Scrupulosity. So this is like moral and religious themes. Obsessive thoughts, kiddos I've worked with, thoughts just like intrusive thoughts with profanity, like using profanity, anti-religious thoughts, satanic content. And a lot of times this does happen in people that have like a strong faith base. So it is really upsetting to them that these things are popping in and are not things that they believe in and that they find are very upsetting. So sometimes, there's that lingering doubt of like, but did I do this? I feel like I probably did it. So I need to like undo it, or I need to check and make sure I didn't, text a friend with profanity or say something, to my mom that I hate God or something. So a lot of like just reassurance seeking. Um, and I had one kiddo that like was having some thoughts about like reincarnation and just religious thoughts that were different from his own, and just kind of wondering about that. But that prompted a lot of guilt. So guilt is a very strong thing with scrupulosity. So the compulsions that go along with it often are like excessive praying and seeking reassurance that they did not do the things that they're thinking they might have done. One kiddo, there was his OCD was really kind of triggered by some pornography viewing. And then afterwards, he was at a pool. So that's when he first recalled having some of these intrusive thoughts. And so he avoided going to that pool because that's where all of this started. All right. So a need to know or remember. So this is, a way of trying to seek certainty in an uncertain world. And when we get into the part about treating OCD, that's a big part of it, is just learning to kind of sit with that uncertainty. And so excessive concern about making the right decision. So we see lots of people with OCD who have tons of like indecisiveness, huge problems with that. Repetitive checking behaviors to make sure they did or didn't do something. So checking locks, checking for like, do I have my phone and wallet? Making sure nothing terrible has happened. Let me look online or on social media to make sure like, there hasn't been an earthquake or a car crash or something like that. Lots of, again, repetitive question asking. And then another one that kind of goes with this, like needing to confirm things like their sexuality, or if they said the right thing, if their parents love them. So lots of just things that's like very draining for the other people in this person's life, because they're asking the same questions and they're even, like, I've already answered that. I've told you 5 times, the answer's still the same. So they can get really, kind of frustrated and short-tempered with these individuals, because the way that it presents itself, this is one that involves other people sometimes. All right, so symmetry and just right. So this type of theme usually lacks the belief that something bad will happen. So it's not like, oh, if I don't, make sure that my shirt's tucked in evenly on both sides, something bad's going to happen. It feels uncomfortable. Like when I don't like the way that it looks, those types of things. So repeating things until it looks or feels just right. So I've worked with kids that had to like look at things in a certain way or blink in a certain way. Again, this can be distinguished from like autism, because sometimes there are some like differences in visual perception, the way that individuals like look at things. They may kind of side eye things or look at things from odd angles. But this would be more like just, okay, when I look in a corner, I have to blink twice, something like that. So brushing your teeth, flossing in a certain way. So again, it's good to have, kind of a routine and a consistent way to do things. But when it's like obsessive, like and compulsive, when I can't do it that way, it brings on much distress. That's sort of a difference. So stepping through doorways in certain ways, or having to do it like 2 or 3 times, or on or off carpet. So when we're changing like floor types, lots of erasing and rewriting. I talked to a kid the other day that's like, if I write a word in one letter, it looks off, I have to erase it and rewrite it. And mom confirmed, like, yes, it takes a substantial amount of time to get homework done because of the amount of erasing and rewriting we're doing. Rereading things. And again, not the rereading, like, oh, I kind of blanked out in the middle of that. Let me reread it. Like, but just feel, okay, I have to read it 3 times every time. So again, having to do things a certain number of times, having to make things symmetrical, um, checking to make sure they haven't made a mistake. And I find that these kids often get really stuck in loops. Several parents have described that, like she gets stuck in a loop or he gets stuck in a loop and can't seem to break out of it. Like he's just gets stuck there. And again, this is where like that excessive superstitious behavior could pop into. All right, so some tools to assess pediatric OCD. Okay, so these are all self-report measures. This would be part of a more comprehensive evaluation. But the SIBOX, so that's the Children's Yale Brown Obsessive Compulsive Survey, I think. I forget what the S stands for, but that is really widely used. It can be done in an interview format, like with a family, with the parents, or even with the kid if they're old enough to articulate these things. So it looks at both, current obsessions and compulsions and past obsessions and compulsions. It gives lots of really good examples, so that can really help flesh things out. Because again, a lot of times people do things, or parents may see their child do things but not recognize that that's part of OCD. So it really helps flesh that out. I also like to use the one on the bottom, the family accommodation scale, a lot. So that's typically done more in therapy once we have the diagnosis confirmed, to look at how much is the family bending to the needs of this child because of the OCD. Are they, not, we're not going on vacations, we don't go out to dinner, we engage in these really long bedtime routines. We avoid saying certain things, wearing certain colors, or, whatever it might be. So it kind of assesses for some of those. So that one's another one I like a lot. For the kids, there are several self-report measures. There's also a kid version of the family accommodation scale where, again, depending on that level of insight, they may be able to say how much they have avoided or not done things or done things differently because of their OCD. I also like the FOCI, the first one on top there, the Florida Obsessive Compulsive Inventory. I give that probably to like older elementary and up. I don't give it to super young kids, or for some of them, I'll read it to them because there are some allusions to like sexual content or things that may make younger kids uncomfortable. And if I can kind of tailor it in the way that I say it if I read it aloud to them. So, yeah. So those are just a few assessment tools that I like. And then, so treating pediatric OCD, we're going to get into the how-tos now. So first level of treatment, kind of like Lisa mentioned for anxiety. For mild to moderate OCD, there's a specific type of CBT called ERP, exposure and response prevention, and that's the most widely used kind of gold standard for treating OCD. So when symptoms are moderate to severe, sometimes combined approach of ERP plus medication, should be considered. And about 70% of people will benefit from ERP or ERP plus medication. So that's a really pretty high percentage. Obviously we'd love it to be 100%, but that's pretty good treatment efficacy. All right, so what is ERP? So this uses planned exercises, helping the child or individual face whatever they're feared. The fear is basically. So that's the exposure part. And while refraining from unproductive safety behaviors. So those are the compulsions. So that's the response prevention. So we kind of expose them to what upsets them and keep them from doing those compulsions, because that way they learn, I don't have to do this thing to be safe. So we do this kind of incrementally in small doses, and I'll go into that more in a minute. And then in a controlled environment. And one of the rules for ERP is never ask someone to do something you won't do yourself. So, so they can kind of have this safe environment to experience the anxiety or distress and recognize, hey, I'm making it through. I'm doing okay. So one of the first things we do when working, especially with kiddos, and this works with teens and adults too, is we work on externalizing the OCD. So giving OCD a name can be really helpful. For some of us, we just call it OCD, but for some people, it's fun to kind of make a character out of it, so that when we talk about OCD, we can refer to it as this separate thing. We can talk about OCD as a bully. I actually had a 19-year-old earlier this week that came up to on that on his own. He's like, so OCD kind of sounds like a bully. It's like, ding, 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 good job. Um, and then we use lots of metaphors with OCD, which I love. Like I talked about before, we have the river with the net and the thoughts getting stuck in the net. We talk about, OCD thoughts as being like spam or junk mail, like it just got through our filter. It's a computer glitch. It's on the dryer, it kind of cuts off when we know that it's done. Well, our all done switch is not working right now. We get stuck, those types of things. We talk about the unwanted party guest, where you have a party and somebody shows up that you didn't invite, and they're just kind of sitting over there. You notice they're there, but you can still focus on your friends and have a good time. And then we use some cognitive tools like reframing, so kind of looking at those underlying automatic negative thoughts. We can kind of replace some of that with positive self-talk. Identifying and correcting other kinds of cognitive distortions so there's like a psychoeducation component to this too. All right, so some tools for exposure. So we can do like imaginal scripts where maybe like we're talking about what the feared thing is. I've had kids write stories or kind of make up like creatures and like have like a whole imaginative thing. Overlearning, so that can be if there's a certain word that's upsetting or a certain type of thing that's upsetting, we write it on a piece of paper, or we make a crossword puzzle and like have the uncomfortable thing. So we try to make sort of games out of it and make it sort of fun, and kind of silly, kind of take some of the power away from it. And then gradual exposure, like fear hierarchies are one of the big tools we use for exposure. So let's talk more about that. And this is similar to what Lisa was talking about with the fear thermometer. My conceptualization is a ladder. So in creating a hierarchy, so the therapist works with the child and the family as well, to identify kind of what I kind of do it by theme. So for this theme, what are some upsetting situations? And then we kind of rate them. So the lower on the ladder are going to be the less distressing, higher up on the ladder are the most distressing. We can have kids assign like a 0 through 10, what is their level of distress when they think about that. That can kind of help us. For younger kids, I might do like small, medium, large. I draw like McDonald's French fries containers to kind of help them conceptualize that too. So what happens is we work on exposures one at a time, usually starting kind of from something that seems more manageable and working up to the more distressing things. It may be necessary to repeat the same exposure until they get used to it. So it can take some time to work through these. And kind of as we move up, I mean, it's a huge accomplishment each time. We're like, hey, we conquered that. Great job. I liked Lisa's patient's idea of making like the success tree and like putting the leaves on it. So that would be a very applicable thing to do here too. All right, so some alternative to hierarchies, because true, like straightforward ERP, that's what you do every single time. I kind of put my own spin on things a little bit. I like doing it a little bit differently. So I don't use the SUDS a whole lot. I'll just maybe initially to kind of get an idea of how distressing things are, but I don't have kids continue to rate themselves like while they're doing exposures and things like that. I typically am just like, did you make it? But I like to do bingo cards. So we'll put stuff from their hierarchy on bingo cards. I'll put some free spaces on there. And then that can be part of their homework, is to bring me back a bingo. And then they get like a special prize for that. So that's a one that I like. I like using multi-sided dice and put different exposures on there. And like we roll the dice to see what are we going to do today. And then like using some principles from ACT. I really like the values kind of portion of things. So we do talk a lot about that, that willingness to sit with OCD, like kind of the unwanted party guests. Can they sit in the same room and you not be upset? Or then aligning with personal values, like we talked about before. A lot of times things that are distressing, the reason they're distressing is because it's so counter to what the individual truly believes. So knowing, hey, is this what do you want to keep doing this compulsion? Do you want to keep having to check this or wash your hands or do these things? Or would you rather be like hanging out with your friends or your family or drawing or doing something you love? So let's focus more on how can we get to the things that we love, and it sort of shifts the focus away from the distressing thing. And we can learn to live with it just sort of in the background. And then there's a newer kind of approach. It's also CBT related. It's inference-based cognitive behavioral therapy. So that really shifts the focus from like fear and tolerance to correcting. It's more like more the cognitions. So the errors behind this obsessional doubt. I don't know a whole lot about that because there's only so much room on my plate and I don't have room for that one right now. But I do know some people have found success with that, especially if they haven't done as well with ERP. And I think it's used more with like adolescents and adults because they do need to have that level of reasoning. Let's see, did I go too far? Nope, I did. My bad. Now it's not going to work. What am I doing? Okay, sorry. There we go. All right, we talked about that. Okay, so outcomes of ERP. So the hope is that the client child will be habituated to the OCD thoughts. The response will diminish. They'll be able to give up the compulsion. So again, some more metaphors. It's like when you jump in the pool and the water's cold at first, you go, oh man. But then after a minute or two, you're like, you know what? It's not so bad. And then you just kind of adjust to the water temperature. Or go walking into the movie theater and the lights are down and you can't see and you're like, oh, I hope I don't step on somebody. So you find your seat and then after a couple minutes you're like, oh, I can see the chairs now, I can see people. So your eyes kind of adjust in a dark environment. um, so yeah, children learn that they can allow their obsessions to come and go without the need for the compulsions or rituals. So it stretches those holes in the net, lets those kind of weird distressing thoughts through. We don't have to focus on them anymore. And then it helps children to really be, and individuals to be more in charge, to feel like I'm not letting OCD be in charge of me. It's something that I can choose when and how to respond. And do I really need to engage in this thing? So that's really empowering for people to be able to say, you know what, OCD was telling me this, but I decided I was going to do this. So yes. And then someone had the question here about, is naming OCD as a bully helpful because it helps it externalize it from the client? And yes, it is. It's why we want to give it like another name. We want to give it something to call it, because like I said, lots of times it's counter to the person's values. So helping them to look at it as something that's out, like separate from themselves, can be really helpful. And it helps them feel better because, like I said, there's lots of guilt oftentimes associated with OCD. So taking that away can help that guilt. So the role of the family. So Lisa also had mentioned how important it is to have the family in treatment. And OCD, it is super important because so much of what we do, we can practice in session, but it's really up to the individual and their family to continue working on this, because it is and exposures are something you have to do outside of session. You can't just do them in session and expect to make any progress. Yes, so as I mentioned before, especially with the family accommodation, OCD can be very overwhelming. It can just change the family structure. So what part of the psychoeducation and why I oftentimes work with the child and their parent in the session together is so that everybody gets the same information. They're on the same page when we're doing, discussing what OCD is, when we're talking about externalizing it, all those parts in the process, the parents are right there along with them so they can help remind the kiddo, once we're gone, here's what we talked about. Oh yeah, Dr. Smith said this. What do you think about this? And they can just continue to have like an ongoing conversation using the same language. So parents are taught how to change their engagement with their child's OCD. Like I said, kind of fading some of those accommodation behaviors, offering encouragement. So we're changing like the supportive language that we're using. Lisa had mentioned SPACE as being a really good family, like a parent training program. And it absolutely is. This is in later in my presentation, the resources, but this is a book that is made by Ellie Leibowitz, who started SPACE. And this is a fabulous book for parents and for clinicians, because you can read through this and incorporate these principles in psychoeducation for the family, because it really talks about Again, just changing the way that we talk with kids, not saying like, what's wrong with you? You can do this. Just do it already. That kind of stuff. Like, why can't you do it? It's so easy. To changing it to more supportive language while still not saying, well, I'm just going to do it for you, or I'm going to like allow you to continue in this maladaptive way. Right. So, yeah. Okay. So reassurance trap. We talk about this, especially with parents. So many kids with OCD and just individuals in general have a difficult time tolerating uncertainty. So just being able to sit with that uncertainty, they want a definitive answer. That's why we're checking. We want to be sure. We want to be sure that it's done. We want to be sure of this, of that. And learning that in life there are very few things we are actually sure of, that there is uncertainty, and we need to learn to live with that, and to feel okay about that. So we can't have definitive answers to our questions all the time. And I think parents, well-meaning, try to provide that reassurance. And in some instances in people without OCD, that can be helpful because that's all they need. They just need like that one, maybe 2 times of reassurance. And then they're like, okay. But with OCD, it's never enough. So anytime it's like, okay, yes, we're going to, we'll stop by Buc-ee's on the way to school or whatever. Oh, yes, we'll stop by Buc-ee's on the way to school. Like, and it just keeps going and going. And the child never feels satisfied because OCD continues to place that doubt in their heads. So, and if parents are engaging in a lot of reassurance seeking, it can really keep us from making progress in therapy, because they're just not contributing in a positive way to the treatment, even though they may be well-meaning. All right. So we mentioned before about medication and OCD. So I wanted to go into a slightly more detail on that one. So again, first line for mild to moderate is going to be ERP. Moderate to severe, we may need to look at some medications. So SSRIs are the first line evidence-based treatments for OCD. They're most effective. They're generally pretty well tolerated, and there's lots to choose from because everybody's body chemistry is a little different. If one of them is not the right fit, we have some other options. Interestingly, with OCD, they often need significantly higher doses of these medicines to achieve a therapeutic effect, because for anxiety and depression, it is generally lower dose, like lower to middle doses, but with OCD, it is a lot higher. And prescribers hopefully will know that or have access to that information once they find out the person they're treating has OCD. So another one, clomipramine, is a tricyclic antidepressant that also is really effective with OCD, but it has a higher potential for some negative side effects. But that is another option. And then more recently, they've found that augmenting some of these first line medications with like atypical antipsychotics can be helpful. I'm not a prescriber, so this is not my area of expertise, but just knowing that these are some of the possibilities that can really help if an individual does need that extra medication management help. All right, so this is the pediatric OCD protocol. I put in there later in my presentation, I have this book also by March and Mull. This is like the guidebook for treating OCD in younger people. So it's super helpful, and I kind of summarized how they break down their treatment plan. So the first couple weeks are psychoeducation, building rapport, kind of talking about OCD, introduce metaphors, and learning to externalize the OCD. So then in week 2, we can start some of that mapping OCD, where we're creating like bossing back OCD. We're learning to basically identify what is OCD versus what is not OCD. Determining what are some of our themes, what are our compulsions, what are we avoiding, how is life harder for us because of OCD, and then trying like some easy trials of exposure response prevention, just to gauge like, are they able to do this? Can they be compliant? Are we starting at too high of a level? Do we need to back off to something that's like feels even simpler, just to help them feel some success? So kind of testing the waters. And just learning more about their specific OCD themes and needs. And then weeks 3 through 12, we have exposure and response prevention. We're also addressing other variables like comorbidities, severity. So talking about, how is this impacting us at school? Continuing to work up those hierarchy ladders or however we're doing our exposures. We can use imaginal and in vivo work. Some people in private practice will do like community exposures. If that's an option, that's fabulous. I have to kind of trust, like I have to assign those things for homework and let the families do them on their own because we can't really do that here. But in session practice and homework, like one of my kiddos, the one I talked about earlier, that with the like drinks that were other than water, some of her exposures were to like walk down the soda aisle in a grocery store, go through the drive-through with her mom when she was ordering from Starbucks. And we kind of worked our way up where mom would have like a drink on the other end of the counter and we would move it closer and closer to her. And eventually she got to where she could hold it if the lid was on, and then we worked on, okay, well, what if the lid's off? Can you still hold it? So kind of working our way up. And then the last couple weeks are relapse prevention and generalization training. So we're hoping by weeks 11 and 12 that kiddos have felt some mastery in their exposures. We're making really good progress. Parents are reporting less distress at home, less compulsive behavior. And then we're kind of planning for the future, those types of things. Now, obviously, a person that has more themes going on or more comorbidities or things like that, it can last longer. But, in a perfect vacuum of this is just OCD, this is kind of how it goes. So, and somebody asked the frequency of the sessions. So when first starting, I like to meet weekly for the first probably maybe 3 or 4 weeks. And again, it depends on the severity too. So if this is something where we're going, oh my goodness, this is a lot, you guys are really distressed. Yes, let's meet weekly for the first few weeks and like helps build rapport faster. It helps us make progress faster. And then we can look at kind of reducing to every 2 weeks. And then eventually I usually do like monthly check-ins and then we'll try, okay, let's do a trial of let's try 2 or 3 months and see how it goes. Or we might move to a like, I'm here, call me when you need me kind of thing. But one of the things with the relapse prevention and generalization training is reminding these kids individuals that they have the tools they need. And one of the great things about this protocol is that you can apply it to lots of different themes. So sometimes it's just applying our tools in a different way. And I always say, if you get stuck and you aren't able to figure out how to apply your tools, then we can meet and we can talk through it and we can give you some ideas. So I'm always open to kiddos coming back as needed, because with OCD, it does tend to kind of morph over time. And they can be, really successful and doing great. And then there's a new stressor that happens and, there pop up some of these things again. Actually just had a kiddo that I worked with when he was probably like 13 to 15. He was actually my first OCD patient. And the reason that I started learning more about OCD, because I was like, I don't know what to do with this kid and I don't want to make things worse. But anyway, so he had stopped therapy for a little while. He came back recently at 19 and he is very motivated. He recognizes that some of the things he's doing are maladaptive and he really wants help, and it's fabulous. So I'm happy to work with him again. Let's see here. So then here's my case example. So this, when I say was the prototypical like OCD in a vacuum, this is it. This is like the best case that just shows OCD. So the background of this kiddo, let's see, I don't know how much time I have left. I know I'm getting close. 10-year-old female. She was generally healthy. She's super kind, gets the kindness award at school. So had sudden onset behavior changes after a positive strep test. As far as the family knows, it was her first strep infection. Symptoms weren't severe. She just had a little bit of a like sore throat. Parents took her in. It was strep. Not a big history of that. But then she began exhibiting some blinking tics and like gasping for air. She did have a history of some transient tics. She felt like she needed to urinate, but then didn't feel relieved after using the restroom. They checked her for UTI. That was negative. And then about 3 weeks before I met with her, she started having some intrusive thoughts about just negative thoughts about other people. Like some of it was like harming family members, but then it was other things like that. I don't like that girl's hair. And it was like very distressing to her of like, why would I be thinking I don't like her hair or her outfit? Um, she had some worry with germs, especially like if she touched herself. She said that she felt like there was like a residue on her fingers. She had some issues with like symmetry and routines, with hoarding. Um, and then she did tell me, which was news to her parents, that the intrusive thoughts were new, but the germ and symmetry stuff had kind of come and gone in the past, but it was never this severe. So I completed the DI with her and her mom. We talked about OCD, encourage them to start to identify and label the intrusive thoughts. And again, the opposite of what you really believe is probably OCD. The family was already doing like distraction really well to help her with sleep because she said at night she would have a lot of these intrusive thoughts. So they would give her other things to think about, like, oh, create your favorite roller coaster ride, or if you were gonna make a dress, or like plan a vacation, or just giving her something else to think about. So based on her distress, I actually talked to the family about considering medication. They and they thought about it, and but that's not something I always do. I don't always jump to that. So we planned for weekly appointments, and her homework was to identify OCD thoughts. So second session, she was doing well identifying the thoughts. We talked about visualizing and naming her OCD as something separate. We introduced the concept of talking back to OCD being okay. She had like some struggles with that because she, is very respectful and kind and compliant. And just, even her mom having to look at her and say, it's okay to say no to OCD. Um, so, and then I shared my concern because she was constantly telling mom her OCD thoughts, that this has now become a compulsion. And mom was like, yeah, I think you're right. So we talked about how we can vary how she does the confessing. So we set aside time for it each day, or we kind of do a rating, like she would do a rating system and only just report the most distressing ones. So I kind of am trying to like back that off slowly. Provided mom with the Leibowitz book that I shared, and then her homework was to create her own OCD character. She's very creative, so this was awesome. So she shared a drawing in the third session of her character, who was a half bull and half hawk, and she had him there. And the family had come up different ways to share the OCD thoughts. She said that she started only writing down thoughts that repeated. So if it was a thought she had once, she didn't write it down. If it was coming back, she would write it down. We practiced, like she had her little character, so we practiced talking back to him in the session. This is a workbook that I use that's also in my resources, What to Do When Your Brain Gets Stuck. I use this one a lot. Has a lot of really great tools in explaining OCD and treating OCD. So one of the ones we used was making your thoughts funny or boring. So she came up with some great ideas for this of like, oh, Bach, you know what? You just keep telling me about other people's outfits. Like, why do you even care? Just stuff like that. Why she was just trying to like make it kind of ridiculous. She reported that she was feeling more confident after each session. So we were working on that for homework. And that was the first time she had met individually with me because mom had to work. Session 4, she independently started writing the story about her OCD character as her origin story, and it had like a little one of those like spinning wheels, like in Wheel of Fortune, and it had her name on it, and it was just like luck or bad luck, I guess, that it happened to land on her name, and they were like, we're going to go bother her. So I love that conceptualization that it wasn't anything she had done, it was just the OCD. She herself was using a lot of great metaphors and analogies and imagery explaining her understanding of OCD. So she was able to take the things we talked about and like add it into her story, and it was fabulous. So she had worked on making her stuck thoughts funny or boring. We talked about that unwanted party guest idea that I talked about earlier. And then I did have her do a little rating, and she said pre-treatment she was like a 6 or an 8 distress wise, and she was currently about 3 or 4. I would say pre-treatment she was probably a little higher than that, but yeah, whatever. 5th session, she reported that the OCD had been more prominent lately. So she started trying to anticipate something he would like what Bach would say. And so she was trying to do that neutralization where we're countering a negative thought with a positive thought. So we talked about that being a different form of OCD. And we needed to kind of try to reduce that because that was taking her out of the moment. She, wasn't able to engage in conversations and be with her friends because she's always, well, what's the thought going to be? What can I say instead? So we kind of talked about how that was not really functional and adaptive for her. Reminded her about making things funny or boring. We could even, like, I like to give kids, here's something you can say. Let's think of what can you say in this? Well, that's just your opinion. Your opinion doesn't matter to me. And we just talked about even envisioning doing some imagery of like turning down the volume on Bach. Like, no, I can't hear you anymore. I've turned you down. I've muted you. And then she said she's been confessing and reporting thoughts to mom more often. So we kind of reviewed some of those strategies too of how to delay and change that up. Because one of the things with OCD is, OCD wants you to do it in a specific way. So even if you switch up the way OCD wants you to do it, that is still taking power back for yourself. Session 6, she was doing well, still having some intrusive thoughts, but they were manageable. We discussed some 504 and school accommodations, especially around using the restroom. That was a real, kind of fear for her, and discomfort in larger restrooms. So we talked about maybe using the restroom by the nurse's office. We talked about that urination compulsion, and she, she had some insight on that. So we kind of worked on that one using some of those same like, how do you know when you're done? Kind of some psychoeducation on that. And she was to work on reducing reassurance seeking behavior. So next session, she reported things were actually going pretty well. She was finding herself wanting to confess to mom again a little bit. So we're just reviewing these strategies every time. Hey, if that's not working, let's change it up and try something different. Something that is really good is, I have this one in there too, the Big Book of Exposures. So if you get stuck on something of like, I don't know how we do exposure to this, they have tons of different categories and ideas, and can kind of help you think out of the box if you kind of are struggling with a certain compulsion. Let's see. And then, she did note that mom is also good about helping her. I mean, she had great family support for this. And then session 8 was first summer session. She talked about, OCD is still kind of there, especially when her mind is more idle. So we talked with mom about building some structure into the summer with, maybe sometimes for reading and sometimes for art and just things that she can do to have a little more structure during the day. She and her perspective was like, I'm still confessing some stuff to mom. Mom's like, yeah, it's pretty rare at this point. So again, that self-perception can be a little different between the parent and the child. And then we talked about self-compassion, because I think this is a kid that typically is kind of perfectionistic. She's kind of hard on herself. Some of her stuff was linked to guilt. So I thought that was an important conversation to have. We discussed kind of the normal course of OCD. Again, like I mentioned, how these tools can be effective for different things that come up. And at that point, she really was doing fabulous. I kind of planned, I was like, it's summertime. I know you guys are really busy. Just call me if you need me. I'm here. And this is a family that would do that. And then something we could work on in the future is some of her perfectionistic tendencies. So after that, like, she's been doing fabulous. I really want to reach out and just check in and see how she's doing. But she was the kid that picked up on this so fast, and she just got it. And it was really cool to see. So here's some of my bibliotherapy stuff. These are some that I've shared today. Here's some that are for parents. Got some for kids and younger kids and references. Okay. I know I went over on that. I'm sorry.
Very good. Thank you so much, Dr. Smith.
Yeah.
We're just going to answer a few questions, and then if you wouldn't mind, maybe just going into the chat and answering a little bit later. So let's pick 2 questions. We have one from Maria. How do you keep the overlearning strategy from intensifying or increasing obsession? Is the intent to weaken the fear by learning more about it?
Yes, pretty much. That's because it's more of like a fearful avoidance. That's when you would use overlearning. So it's almost like overcorrecting it. So if we're like avoiding the dog because he's slobbery, now we want to spend lots of time hugging the dog. It's kind of like going into the opposite direction because they're avoiding like a feared thing. So yeah, that's why we would, an instance where we would use overlearning it. We wouldn't want to contribute to like having her, like in this case example, having the girl write down her obsessive thoughts repetitively necessarily, because that can make her focus more on them. So in the case where there's avoidance, you maybe want to use more of the overlearning.
And then just a quick follow-up on the protocol that you reviewed. What frequency of sessions do you recommend for your protocol?
Okay. I think I kind of addressed that when I was talking, but typically I like to have the first few sessions, probably 4 sessions weekly if I can. And then depending on how they're doing, we can like push out to every 2 weeks until I feel like they've really mastered the things that they need to. And then we can do some monthly check-ins and kind of decrease as needed from there.
Well, we'll just keep track of some more questions in the chat. And you can, any other questions, just keep them in the chat and we'll try to address them as time goes by.
I will.
But
And
now
I'll also, oh, sorry. Emily, I'll also put my email in the chat. If anyone has questions, they can feel free to email me too.
Perfect. Thank you. Okay, so now I'd like to introduce our next speaker, Dr. Rhonda Johnson, who will be talking with us about therapy considerations for treating separation anxiety. She's an LPCS, LMFTS, registered play therapist, supervisor, trust-based relational intervention practitioner, EMDR consultant, and somatic experiencing practitioner. She's the founder and owner of the Center for Counseling and Family Relationships, a large thriving group practice that was established in 2007 and specializes in family systems and trauma-informed approaches. Dr. Johnson is also the founder and owner of CCFAM Training, established in 2012, and Play Therapy Training Resources, established in 2021. Through these companies, she provides continuing education, supervision, and consultation. So thank you so much, Dr. Johnson, for being with us today.
So today, yes, we'll be looking at the practical applications in treating its separation anxiety disorder is what we're going to look at. And so let me get this to get to the next one, and I'll get you to, here's the objectives. So we're going to look at, just for a minute, pandemic and the impact and technology on anxiety. And then we'll look at presenting the case study that I'll show you today, parenting behaviors that contribute to anxiety and therapeutic modalities, and to family play therapy interventions. And let's see if I can get it to move over. Here we go. And then the case study, like the therapeutic outcomes, so that you can know what happened. So as I jump in, so I'll go past this because they have covered a ton, which is awesome. So Dr. Elliott and Dr. Smith did a great job on that. So as we look at pandemic impact on anxiety, just a couple of things that contributed to separation anxiety as well. Obviously, there was the uncertainty of the future and loss of structure. Then we've got that leading into discouragement from socializing and building relationships. That then brought in the masks that everyone was wearing and the facial cues that couldn't be seen anymore, and the lack of trust. And you've got the reduced opportunities for relating at school with extended family and in extracurricular activities, and then increased time on technology and just technological devices overall. So all in all, I saw some changes with the children that I was working with during that time, especially when it came to separation anxiety and generalized anxiety disorder as a whole as well. The next one, so we'll go into the case study. So this child actually started before the pandemic. So as they started, they were a 5-year-old male. They had been adopted within days of birth and had been placed in their adoptive home. So what made this situation a little bit trickier was that there was a female sibling who was a biological child. So the parents had decided to adopt after not being able to have children, and as sometimes happened, they did get pregnant in the adoption process and decided to go ahead and move forward with the adoption. But because there was only a few months difference in age, it led to a lot of confusion as they would meet people. New people in their lives or people that didn't know them well, even at school, anywhere they went, because the question would come up of being twins, but they weren't twins, and there was a little bit of an age gap, but not very much at all. But definitely some struggles when it came to one being a biological child and the other being an adoptive child, and that's the one that I was working with. So as I started working with him, he lived at home with both his parents and then with his sister and his adoptive family. So things that we saw on the history form symptom checklist that we use when kiddos come in and their parents complete, there was arguing, conflicts at home, defiance, destructive, disobedient, disrupts family activities, fearful, headbanging, hitting, isolates and thinks his friends don't want to play with him, lacking respect for authority, nervous, pouts, refuses, relationships with siblings, conflict, stubborn, temper tantrums, wetting and soiling, and then yelling. So these could lead to a lot of different diagnoses. Obviously, as you're looking at them initially in any initial intake session. And so as I started working with them, we'll look at what happened from there. So in that first session with the parent and parents and talking with them, they did both come initially. There was a lot of aggression that was centered towards mom. So that was hitting and pinching and biting. So not necessarily towards father, but towards mom. There was hitting his head on the floor. Mom was able to link that the behaviors began after sending the birth mother a happy birthday video. So as an adoptive parent myself, we've attracted a lot of adoptive families here in the practice throughout the decades. And so this was one in particular that they had chosen us for that reason. And that question comes up of how much contact, should there be between a birth family and for how long and at what ages do you consider, and making decision making along the way. So when you have that grief and a disruption that's early on in life that wasn't chosen, like an adoption, is the separation anxiety, part of that grief that then bleeds over into the family that they're with now and their adoptive family. So those were questions and decision points that we work through on how often they visited. There was a yearly visit at the time, as well as some of these calls that would take place in videos. At that time, there were no issues at school. So obviously very young. So at that point, 5 was in kindergarten. So there was a visit with the birth family once a year on Thanksgiving, and birth family meaning a birth mom at that point. So developmental and social history, looking at presenting problems and symptoms, the strengths of the child and the family, and then the caregiver's capacity to support the child and the family. So those were the main things that I was focusing on as we got started in that initial session. Coming from a family systems background, it's always really important to me to try to find out more about the family and how they're responding and adapting to the behaviors that are happening, to the symptoms that are there. And so that was part of the decision-making point of what I'll present to you today and what I focused on. So I'm really glad that Dr. Elliott and Dr. Smith covered all of the things that they did, because it gave a lot of background and tools and handouts and all kinds of things that you can do. So what we'll look at with this one goes more into what was done with the family itself. So the initial symptom, as we know, is rarely the whole story. So it provides a doorway into understanding more complex family or emotional dynamics. And that's something that I use a lot, even in supervising and in helping others, is there are the symptoms that they're coming in with, but what really is at our root, and what might our root issues be, and how could we help to navigate the struggles that they're having at that point in time. So there's a mistaken goal chart that I'll turn to a lot, and you can find this one online. It's in the references, and it's on a website called Positive Discipline. With this, I know it's very small print, so it may be hard to read, which is why I'm referencing where you can go back to. But on that left side, it has what the child's goal is. So whether it's undue attention, misguided power, revenge, or assumed inadequacy. The thing that I love about it, it goes into how the child responds. So what their behaviors might be based on what their goal is, and continues on, and it even has the coded message. So what is it that they're saying to themselves, possibly in their own minds, or just the unconscious belief that's never been said out loud or even thought. The second line underneath it is how a parent or a teacher, how they feel when they're with them, which is huge when being able to introduce this to parents, like what are the emotions and the struggles that you're having when this is coming out in your child, and when these behaviors are there, or these beliefs about self, these cognitions. So from there, it goes to how a teacher or a parent might react, and parents can then identify, and it helps to normalize the struggles that they're having versus them feeling like they are the problem, which is a lot of struggle that comes into parenting. None of us feel fully adequate as parents, at least I never have. And you're always feeling like there must be some other tool or something else that you could be doing that could help. So I found by using some handouts like this that are more geared for the parents and helping to educate them and to normalize the struggles that their child's having can really bring, it's like a breath of fresh air, and being able to know that there's a path forward and that there can be some hope. And they recognize, okay, these are the steps that I need to take to be able to make some changes. So I hope that's helpful to you like it has been to us. In the second and the third sessions with the client, and just to speak, I did not bring that handout out at the first session. I give that to you as a tool that we use at some point in the counseling process. So the second and third sessions that we had with the client, so definitely there was a lot of anxiety coming into the room, a lot of curiosity about wanting to know who would clean up. So are they going to be responsible for cleaning up, or would I be responsible? Which goes along with that responsibility that's felt when you have anxiety and wanting to know the boundaries and the parameters. So there was a control and definitely a need to win. So that one lasted for a very long time. A lot of that competition came in, I feel like, because of the biological daughter and being so close in age. The struggle is, along with adoption, just like my child's experience, there can be disabilities, there are diagnoses, there are things that are very different than the biological child might be struggling with. Not that both of them didn't have things to work through, but there's that constant comparison, kind of that question of being twins, just like others had of them. And so with a game, it would be changing the rules, it could be cheating, it could be finishing it before it was completed. And all of these were within those first couple of sessions, and picking up pretty quickly on just how important that competitiveness really was, and wanting to have a belief that they could be good at something, that they were worth something, that there was some value as a person and as a human. So in our play therapy notes, we track like activity level and intensity of play and inclusion of us in the process, and destructiveness and being messy or chaotic. So it's on the scale. So it goes up to 10 is the highest. So it lets you see some of the things that I marked during that time. So theme-wise, there was a lot of exploratory behavior. So relationship-wise, those were some key components for me that I started noticing was a helplessness. And there were actually some pictures that are on the wall that I have in my office. And there was copying those and trying to recreate those, not able to come up with something on their own with their own creativity. An aggressiveness, like with two babies that were buried in the sand. I know a question was asked about that just a minute ago. And a woman that was going to jail, and then a figurine that was going to hurt everyone. So just some aggression that was there that I saw, and then mastery, obviously with the games that would come out really consistently in counseling. And patient stated wouldn't get to come here very long. So obviously there was some of that anxiety that was there on, this is not a place I want to be. It's a foreign place for me, and it's new, and I'm not sure that I want to continue coming here. So I knew that that wasn't coming from the parents. One of the positives of working with this family, which is what allowed it to become such an investment for a length of time, is that one of the parents was in the medical realm. And so there was definitely a lot of buy-in, which was a big help from that standpoint as we got started. So treatment plan wise, looking at it, and the goals that I came up with were to enhance the ability to effectively cope with full variety of life's anxieties. So life was going to have a lot of anxieties, and there were anxieties that I could tell were popping up in lots of different places, all the way from home to school. Even though it started out initially that there weren't any issues with school, those did start coming out over time, as well as with sibling and in other environments like church and other places that they would go. So how to implement some coping skills to help with that overall. A resolution of key adoption issues of loss, abandonment, and rejection. I don't know if those are ever fully resolved, but being able to have an awareness of them and a normalization of them, I think would be important. And then the establishment and maintenance of healthy family connections. So could we be able to be at a point that he could verbalize his needs and wishes, which wasn't happening unless it was happening through behavior, and just parents verbalizing an increased ability to understand and handle acting out behaviors. So again, those reactions of parents and responses definitely have an impact on behavior. So it's more than just the behavior of the child who's coming in, but then we get into the whole system as a whole, because none of us are isolated on our own as silos and needing to consider, what else may be having an impact within the whole system. So, in understanding anxiety, there's that desire, especially for him, and that's where those games came out of that certainty and control, like wanting to know what to predict. I want to change rules, I want to change outcomes, I want to change things at school or at home or wherever I'm at. And that's where it looks very much like control and becomes like running the household, of everyone is walking on eggshells to some degree of when is an outburst or a behavior issue going to happen and what impact will it have on everyone. So there's a desire for comfort and seeking relief from discomfort or distress. So that would definitely be true for him, and it was very evident just as we were in play therapy together, that desire for comfort and wanting to be seen, and heard, for comfort, for worth, for value, more than just when I act out, but value in general. From there, we had a parent meeting at that fourth session, is what we normally do within our practice. So we'll meet with the parents the first session without a child. The second and third, we normally meet with the child without a parent there, so we can start to build rapport and be able to see some behaviors and build a relationship. And then by the fourth one is parents by themselves again. That's where we go through the treatment plan that I just walked you through. Some things that came out in that one that I knew were going to be our major hurdles is that the father voiced questions. There was definitely a lot of questioning regarding how his son could have any issues because of having been adopted, because he had been in their home since infancy. So how can he have any perception of loss at all? Because he was an infant. There's no way that he knew. And that there was no understanding that some of that could even be internal, and then beliefs about self that could come from it. So I already knew that that was going to be a point that likely would need to be focused on at some point in time. At that point in time, as we moved forward, the father only came to the initial session and then that fourth session, and then it was the child participating in counseling for a while. So that's what we'll look at. So let's look at parenting behaviors that contribute to anxiety. The ones that contribute to anxiety, we've got genetic predisposition, which obviously wasn't the case within the case study that I'm presenting, but that biological sensitivity to anxiety. We've got parenting influences. So is there early attachment? Is there a modeling of worry or an overprotection? That can be very apparent as well. In this situation, I would say it was more to do with the attachment with the father as they were getting older. Definitely difficulties there. There was an attachment with mom, which is often the case. That's why the aggression was towards her. As counseling first started, she was the safe person, and so that's why the aggression was there. So the life stressors, so trauma, life transitions, or chronic stress. Well, we had, being a child in an adoptive home, we had a birth mom connection that would be there at times. We also had at that point in time, you could tell at the age of 5 was starting school. So that was another big life change during that point in time. So there were many transitions. And I think even just the classroom setting, they were in a smaller private school. And so there were only a few number of classrooms, and having to divide out the class that his sibling would be in versus the class that he was in, and then the competition between those two, and that constant competition on who was excelling the most at whatever the homework was or that they were doing. So that was also leading to a lot of life stressors. Physical factors, there's medical conditions, sleep disturbances, or nutrition. Those definitely became apparent over time. Sleep was a big one, but there were some medical conditions that were questions there too. Avoidance behaviors like escaping discomfort reinforces the anxiety over time. So that's where a lot of behaviors were coming out, was wanting to escape times that he knew, like the drive to school. There was a lot of anxiety that would build up during the drive. And so we had to talk through things that could be helpful for mom to be doing during that time, whether it was the music they were listening to, or snacks that were readily available, or things that could help to distract, things that would be calming for him. So expectations, core beliefs, or values. So perfectionism, fear of failure, or rigid expectations definitely fit into this category. So whether how much of it was coming from parents in relationship and attachment with them, and how much was internal, remain to be seen. But all of these are root contributors to also consider as to what's, where did it start and how it's built over time, and to consider how much each of these are impacting the situation as a whole. So next we'll look at parenting behaviors that can contribute to a child's anxiety, because I do feel like it's important to cover those when we're looking at things from a systemic perspective. So there's rescuing, reassuring, and overprotecting. So there's providing excessive certainty, so continually guaranteeing outcomes. There's identifying as the worrier, so modeling the worry as part of the family identity, expecting others to accommodate the anxiety. I know that I'm sure happens in schools and in lots of other settings on this is what has to happen for my child because this is what they need, and expecting those accommodations. Sometimes those accommodations need to be there, like we've been covering today, whether it's a 504 plan or a restroom or other things. But this is when it's getting excessive. So it could be anywhere that they're going, whether it's a play date with someone else or whether it's something that the child could take care of for themselves or have a voice, but wanting others to do it for them. Allowing disruptive behavior as an anxiety release. So obviously behavior is going to happen at times, but where it becomes this consistent rotation where it's impacting the entire household with emotional outbursts is something to watch for. Modeling anxious responses. I know for many of us, we may work with anxious children and we're able to see where it's coming from because those patterns are there within the parent themselves too, and there may be a definite lack of self-awareness as well. Pushing too hard or responding with anger. So are those overly high expectations there or frustration? And then becoming impatient with progress. How many as parents we want things to change right now? And it feels like we've been struggling with it forever. And by the time we're going to get help, is wanting to see immediate change that happens and really needing to recognize that it does take, it takes time. I think some of the biggest things, even I know personally as a parent, in seeking help with our own child at different points in time, is really the benefit has come from those providers who've really given hope and encouraged the most. It isn't even so much the tools as giving hope and encouragement to that family and to those parents and to the child that things can improve. And it's just a matter of we'll continue progressing. And it shows that we're not giving up and we're not being impatient in the process as providers too, because that can also contribute to it as well when we're wanting it to go a certain way. So therapeutic modalities and 2 family therapy interventions. So there were several that we did, and I'm trying to hone it down on just a couple that really were most meaningful and that I like to use with families the most are the ones that I'll show you. So for the case study, the length of time was actually 6 years. So you can count, began at the age of 5. So that gives you an idea of where we were ending up as we finished out. The type of counseling that was provided during that time, it obviously began with play therapy, but then there were points in times that we had sibling play therapy. There was definitely a point in time where mom was involved for parent and child play therapy, and then that transitioned into family play therapy as well. That family play therapy, as it began, was the 2 children with the mom. So dad at that point was not interested in being involved or to accommodate schedule and to be able to make that happen, or didn't have the ability, flexibility to do that, whatever all the reasons were that were behind it. Everybody has a different perspective on why that may have been that way. And obviously I wasn't having the time with him, so I can't speak for that. but was able to see a lot of progress taking place for him individually and then in the sibling relationship to help alleviate some of that competition and try to build a bond because we needed an attachment with our sibling as well. And then the parent and the child really being able to have some fun, times with some positive memories, as well as being able to make progress on a positive relationship with mom and sibling at the same time in family play therapy. And then family play with the whole family was able to take place, but it was at a point in time. Unfortunately, like some situations, I had been recommending it for quite some time. So, probably over a span of some years, where it would come up at different points in times. But there was a crisis situation that happened with education setting. And at that point in time, I just defined we had done all these other types and just saying, if you're wanting to make the progress at this point in time, what really needs to happen is for all of you to come in together. And so they did all come in together at that point in time. I think I had had maybe 1 or 2 sessions with client and dad before we had all of them together. And that was even dad's initiative. They had been to the psychiatrist who had recommended at that point, or I think questioned, why is mom and sibling and client, why are they all there in family therapy, but you're not participating? So that gave a little nudge from outside on participating. And so he came in individually with the client with a son, and then we were able to morph that into everybody being there together eventually. So one of the ones we did was Boat Lighthouse Storm. That can be really helpful. You can do these several different ways. So I gave some instructions to try to help. So if you want more instruction, it can be imagine your life right now as a boat on the water. Then draw or describe your boat. So how strong is it? Is it big or small? Is it steady or fragile? Are you alone or with others? So drawing, art, creativity, all these things can be super helpful when you've got younger kids that you're working with. If you wanted to give more simple instructions, which is a lot of times what I do, is the top version, write or tell a story about what happened before, during, and after the storm. So they draw a boat, a storm, and a lighthouse, and that's all that you give them. And then they know that they're going to tell a story about it after, or you can have them draw it and then you have them tell the story after they've drawn it. So that's where you get to have lots of freedom and flexibility. There are lots of ways to go about doing this. And as you know, for every child that we work with, they all need something unique and different. And so this can help in that process that you can figure out what's most needed. So after drawing a storm, if you gave a little more instruction, like what are the storms in your life? Things that are hard right now, stressors, fears, challenges. Draw the storm around your boat. Label or name what each part of the storm represents. So drawing a lighthouse, who's your support system? So you can already tell this is something that could be done individually with a child, but most often I use it with families, and it's so telling and very interesting to watch them. In another male that I worked with, and I had both of these boys at the same time, they were very similar in age, also an adoptive family, but this one was an only child as an adoptive child and the only child in the family long term. And theirs would be a great example of with that boat lighthouse storm, the child immediately rushed to the easel and started drawing. It was very clear that dad was wanting, to intervene some to try to help her. Like, let's talk about this first. What do we want to do? Like, let's brainstorm together, or what color do we want it to be? Even trying to give some interjections, on the questions and hoping to become a part of the drawing. With that specific child, it was very similar as well. That rushing wasn't so much separation anxiety, but those same feelings that were internal of that lack of worth and value. And so if I rush to go do it, that same competition, if I don't have to see anyone else's, so I don't have to judge mine when I am then seeing theirs. So if I rush to do it, then mom and dad aren't having the input in it. And this was a very similar pattern that would happen. So it was definitely, as I was watching it, just seeing that and recognizing, okay, here are the steps we need to take. Here are opportunities in being able to move forward on being able to trust mom and dad and being able to trust that they could work through things together. that child specifically, what happened in that boat lighthouse storm drawing and taking over was very much what would happen at home. So when we were looking at the goal, what are the goals of the behaviors, mistaken goals chart. It left my mind for a minute. As we were looking at that earlier, it's very much that piece of, if I run things, then I have control. I'm wanting comfort. So this is helpful to me to have this certainty. So both of them had very similar goals that they came in for, but it showed differently over time, obviously in symptoms and in things along the way. So I gave you, as you reflect on it afterwards, if whether you've given more instruction, less instruction, there's freedom. You can ebb and flow with this as you go along. But there's, what do you notice about your boat, your storm, and your lighthouse? Tell me about your water. What are life stressors that create waves? Tell me about your boat. So all of those. So it's really something that can be super helpful, because it also, once you sit down together after it's done, and being able to look at, like, what would you have wanted to do different? How would you want it to be the same? Is there anything you'd want to change in the picture? You can use specific questions like I've given you, or you can be able to reflect even with, like, Dad, I was noticing as it was just getting started, you went up and stood behind with some questions. Was there anything you were hoping for at that point in time? Mom, here's some things I was seeing. So it allows each person to have a voice and to see the behavior acted out that normally will happen at all the different places that they go, that they know is occurring, but it being able to happen in the room in real time, and then being able to work through it. It also allows for, if you need parent sessions with them only after that session, let's talk through, like, what are some ways to respond or react based on the mistaken goals? Like, how do you find yourself reacting? Are there some things to do different to help support in the process? There's reflection that we were just mentioning, that can be about, it can be external. It's about the boat, the lighthouse, and the storm, but it also can get much closer to home if that's something that they're open to, because it obviously reflects on their life. So for you, you're going to note, what are family roles that you're seeing, inclusion and exclusion patterns, relational dynamics, and observing cooperation or conflict during the drawing process. So, and using your observations to reflect family dynamics. So I gave you a bunch of questions that you can utilize anytime that you're wanting to reflect on things that I was starting to reference a little bit earlier. So I want to make sure we have time for this next one. So this one is the family aquarium. It's a really fun one as well to do. I did this one with the first case study I was mentioning that I gave you all the slides about. So we'll go back to that original case study. And I had no idea. I wish I would have known. It's like you want to give a talent assessment out when families come through. So the dad actually had done a lot of artistry and had a background in some art, which was definitely a surprise, because in personality wise would be more rigid and structured, which is why attachment had been a little bit more difficult. So this was something where dad could shine, as they were doing it together, anytime I started utilizing these art ones. So it's an imaginary aquarium. It can be 3D, it can be flat on a sheet of paper, it can be however you want it to be. But they make an aquarium, and each family member chooses a sea creature to represent themselves, and they draw their chosen creature. So that's the only instruction that's given, is they're going to make an aquarium, they choose a sea creature, they draw it, and then after they get done, they place it wherever they want, where they feel like it belongs on the aquarium, and they're invited to describe their creature, like whatever they chose. So this is the one from that family in particular. I want you to look at it and see if you notice some things as you're looking. What usually brings out the most curiosity, you can tell pretty quickly, there's a shark in that upper left corner that's about to eat a penguin, is what it looks like. We've got a lot of fish flowing one direction. We've got a couple flowing another direction. So there's some questions. There's a lot of things that came out with this one, and it was so interesting what each family member had done. The fish at the bottom, and I can't remember the name of them, you might remember better than I do, but it is one, it's a dangerous one to be around. So there was a whole story with that fish. And then you have like the rainbow ones that are prettier that are floating around. But it was that one at the top, obviously, that kept grabbing attention. as we were processing it and using some of the reflection questions. Sure enough, the shark was there and the penguin was mom. And I'm trying to remember, I'm sure if I went back far enough, the shark was not drawn by mom. I'm pretty sure the shark was put there and then mom put the penguin at the top, right on top of it, or drew it after the fact to put it at the top. It was getting to such a point because they were at a crisis point in their family and in their relationship. You can tell the penguin is wanting to jump out of the aquarium. There was getting to a point of giving up. Like all the strategies I've used, all the things that I've done, all the things I've applied, and she would apply anything that I gave her. Even at the end of the day, like, are those enough? Like, is there hope? Being able to move forward. So it had so much, it was told so much just in that one aquarium that they then could process, and it gives them the ability to think about it afterward, what they want it to become, what they want it to be like. They can even move things around on the aquarium in later sessions. So there are lots of things you can do, but here were questions that come in, and that's where you've got the predators, the helpers, the fish that are protecting, all those kinds of things. And so the outcomes that came from this, so initiated counseling with a male therapist by the time I got to age 10. So we had done all of these other types of counseling, and no, these were not every week, just to be very clear. Like Dr. Elliott and Dr. Smith would say, would finish out, then life situation would happen, would come back. Okay, then we incorporate some other types of counseling, would finish out, would come back. So it wasn't consistent the entire time that they were with me. But I also felt like it would be a great idea to get an alliance with a male because those that were speaking into his life the most were females, and the birth mom was the only one that he had had the relationship with initially. So we definitely strengthened some family relationships and connection along the way. Successfully, thankfully, navigated that school transition. And guess what? They ended up in completely different schools. So bio daughter ended up in a school and client ended up in another one. There was an increased sense of hope and positive outlook for the future. I never mentioned that, but there was diagnoses of attention deficit along with anxiety that came in along the way and medication that was being used. But our focal point while they were with me was on a lot of the family situation. And I did make a phone call. I know Dr. Smith was mentioning recently, wishing to know outcome of one. I did make a call. I just wanted to check in because they are close to my heart and long-term clients there. So there was an initiation of a nutrition plan because of some negative side effects that had happened with the medication that had been used through the years and most recent ones that had been used. And I was really excited to hear how, that was being transformed and morphed into the client was getting a view of maybe wanting to be a chef in the future and seeing that they could have a job and could be successful in life. So they're now a teenager. So that's the ending as of right now, therapeutic outcome. So I was grateful for that one. So it gives you a spin on it's not just the client or the meds or the handouts or the just right thing along the way, but being able to really incorporate parents in the process and making sure that we're utilizing them throughout the time as well. So that's mine. So hopefully we're going to be able to switch out. I'm going to try to switch out this PowerPoint. You might grab him just in case. I'm so sorry. And thank you for the grace in the process. So if you have questions, I am happy to answer anything while we get this going.
Okay, then I can go ahead and introduce our final speaker, Becky Evans. She'll be discussing practical treatment applications for social anxiety. Becky is currently a counselor at the Center for Counseling and Family Relationships, a large group practice in Fort Worth. She has a bachelor's in psychology from Hardin-Simmons University and a master's in professional counseling from Texas Wesleyan University. She received her license as a professional counselor in 2008 and became an LPC supervisor in 2024. Becky's also a trust-based relational intervention practitioner, and she began her counseling career working as a counselor for a nonprofit agency specializing in foster care, adoption, and family preservation, and then worked as an intervention counselor in elementary, middle, and high school settings before transitioning to private practice. Thank you very much.
So I am going to talk about social anxiety today. I know that Emily kind of shared my experience, and I will say this is an example from my school experience. And so this is a case study that was how I worked with a student with social anxiety in a school setting. So it's going to look a little bit different. Hopefully that's helpful than some of the more clinical cases that we've talked about today. So hopefully that will be helpful for all of my school people, and for everyone just kind of looking at how we do things a little bit differently in a school setting than we would in a clinical setting. So uh, click it. Yay. All right. Thank you. Okay. So as far as our learning objectives, we're going to talk about social anxiety, but also the impact of social media and technology on anxiety. I think we can all agree that that's been a big deal lately that we've seen since the pandemic and just the rise in technology, that a lot of times that contributes to a rise, and especially social anxiety, because it makes a difference in how kids interact socially with each other. And so we will talk through the case study that I used in the school setting and how I use different interventions and ways to support the student through the things that were going on, and also the sense of how school can bring in a sense of belonging and support. So again, a lot of times this was really helpful actually doing this in a school setting because I was there when it was happening. We were in a social situation, and so I got to really walk with a student through how to kind of work through some of those things almost in real time, because she would come down when it was happening and we would kind of work through some of those things together. And we'll talk about the therapeutic outcomes as well, and what that looked like by the end of the year. This kind of took place over an entire school year. And so I'll talk to you about kind of what things looked like at the end of this time with her. So I'll go ahead and put the diagnosis up here, DSM criteria. We all are kind of familiar with that, especially going through this today. But I think a lot of times there will be a lot of teens that I would work with that would say, oh, I have social anxiety. I have the social anxiety disorder. When in reality, we know that all teens struggle a little bit with social anxiety in terms of I get embarrassed or everyone's looking at me. But obviously, if we're meeting the actual criteria for social anxiety disorder, there's all of these factors that we have to consider. And so it's not just I get a little bit nervous when I get up in front of people or there's a big crowd, but it's actually it provokes extreme anxiety. We're going to have kids that are having actual panic attacks when this happens. So it's not just I get a little bit nervous, but it's like I can't function in that setting. And so that leads to a lot of avoidance, extreme distress, and not being able to function because of this. And so obviously we're going to see that this is persistent. So not just, as I'm transitioning into middle school or high school, this has become an issue. This is something that's going to be persistent for, at least 6 months or more, and that it's not due to any other kind of situation that's going on, whether that's substance use or another disorder or diagnosis. So as I discussed, a lot of times we know that teens are really anxious about certain things. They're very hypersensitive as we get to middle school, high school age, hypersensitive about what are other people thinking of me? What do I look like? Do I look like all the other kids? Am I involved in all the things that the other kids are involved in? How are people perceiving me? So we know that teens get anxious about this, right? And sometimes that presents with some school avoidance, like, I don't want to go to school today because, I got a bad haircut and everyone's going to be looking at me funny. Or, this person criticized me yesterday, so now I'm like never going back out to, do that sport or whatever I'm doing because this person had criticized me and now I'm just not doing it. Sometimes they might have some ability to kind of want to withdraw from social activities. So they want to like stay away from social circumstances because it causes some of that anxiety. And sometimes we obviously see some substance use, so trying to self-medicate some of the things that are going on. And so these things are, when we talk about teen anxiety, these are pretty typical things that we would see with a lot of teenagers. I find this chart is really helpful, especially in talking with parents. So there's a lot of times, especially if we're looking at a parent who this is the first time they're parenting a teenager, they want to know, like, is this typical behavior or is this something we need to be concerned about? And so I had so many conversations and still continue to have conversations with parents about like, okay, this is different than when I was growing up, like the technology usage or all of the things that are going on. This is what my teenager is presenting. Is this a typical behavior? I don't know if we can ever say normal because what teenage behavior is really normal, right? But is this typical? Is this common? Is this something that you're seeing in a lot of teenagers? Or is this something that I need to be concerned about? And so it kind of breaks it down for parents. I will sometimes go over this with parents in session, and I went over this with this mom, and we realized with this case study that we were definitely dealing with more of the actual social anxiety disorder. But So if you have kids that are occasionally not wanting to go to school, like, oh, I don't want to go to school today, I'm bored, I don't want to go, that's pretty typical behavior. Whereas if you're looking at extreme excessive absences, we're looking at truancy issues. They will flat out refuse to get out of bed, refuse to go to school, refuse to get out of the car. Then we're looking at a more significant issue. Kids spending time alone in their room or being glued to their electronics. We know that's a very common situation for teenagers now. But if you're looking at a child who or a teenager who almost never leaves their room, they're constantly on their devices. They will not get off. They will not come out of their room. They will not socialize with family or friends or anyone. Again, more concerning. If we're looking at occasionally staying up all hours of the night, especially during summertime, we know everyone gets off schedule during that time, right? Or having restlessness or saying, I can't sleep some nights, or they sleep late sometimes. That's pretty typical for teenagers. But if you're looking at your teen or child is saying, I can't fall asleep most nights, like more nights than not, I can't fall asleep. I'm laying there for hours, I'm up all night, or if they're sleeping excessively, like you can't get them out of bed, they're asleep more often than they're awake, might be more concerning. Mood swings, how many of us know that deal with teenagers or are raising teenagers, that mood swings are very common with teenagers. But if we're looking at excessive changes in mood, so the big swings, like, so we're looking at extreme swings back and forth between happy and sad, or if it's getting to where it's interfering with their daily functioning. Most teenagers that have mood swings can kind of navigate relationships, can navigate typical life. But if we're looking at ways that that's going to interfere with their daily functioning, then we're going to be more concerned about that. So some of the hyperactive, giddy, they're excited, distracted, kind of typical teenage behaviors, as opposed to more like those manic type behaviors. So really risky behaviors. They're engaging in very unsafe things, and almost like the inability to control those things. And we're going to be more concerned with that. Occasionally expressing sadness, obviously, if they're having, times that, they're going to come home and feeling upset. There was a fight with a friend, or I got embarrassed at school, or certain things like that. Sometimes they're feeling overwhelmed because they have too much on their plates. That's very normal behavior. Whereas if we're looking at they're extremely sad more often than not, if they're engaging in self-harm behaviors or having suicidal thoughts, then we're going to obviously be a lot more concerned about that. In those situations. If they're having difficulty in new situations, that's normal, right? If you're having a kid that's transitioning to middle school or to high school or just a new school year, there's going to be some anxiety in that. There's going to be some feelings of like, oh, I don't know what's going on, worrying about what's coming. They might be a little bit anxious or nervous. But if it's going more towards the side of refusing to be in public, again, having those panic attacks where they actually cannot function and cannot think about the future without having some really intense feelings about it. And the last one is talking about experimenting with drugs and alcohol. Even though as parents, we would like for that to never be the case, we know that that is typical teenage behavior. But if we're looking at any of those behaviors above, so any of the really concerning ones, and they are self-medicating pretty consistently with substances, and we're going to want to intervene in that way as well. So I go over that a lot with parents. I think it's really helpful just to kind of differentiate between what's typical behavior and what we need to be concerned about. So when we talk about the impact of social media and technology on anxiety, we know that that's had a big impact. So in a lot of there's tons of different ways it's impacted. These are just a few that I'm going to highlight today. So losing the ability to socialize in person. So how many of you have seen a group of teenagers and there'll be 5 of them gathered around and they're together and they're all on their phones and staring at their screens, right? So they almost like don't know how to interact sometimes because they're so distracted by devices. And so kind of losing that ability to socialize. A really big part of socializing and having kind of that back and forth communication is reading facial expressions, right? All of those nonverbals. We're used to being able to like look at someone's face and make eye contact and kind of get that back and forth feedback. And so when you're on a screen, you don't get that. So you're just trying to like figure things out by text or what someone's saying. And so you're not able to get kind of that back and forth out those mirroring habits that we do, you're not able to get that. And so it's harder for kids to be able to like pick up on facial expressions and nonverbals. Sometimes these relationships that they'll have are not as deep and meaningful when they're not face to face and in person. And kind of some of the inability to feel empathy or makes them feel like their comments are not real words. All of those things kind of go together because it's really easy to type something or to comment something on social media or through texting that you wouldn't actually say to someone in person. And so it kind of disrupts some of those really deep, meaningful relationships that kids have because they're kind of losing that ability to really connect in a way that, that is really meaningful. And sometimes I would have kids that would come in, because we all know if you work in a school or even outside of a school that kids a lot of stuff happens outside of school that they bring to school and then we have to kind of help them navigate. And so we would have so many times kids would have things happen at home on the phone and they would come in and we would get the kids together to talk through things. And it was like a totally different situation because when they were in person and they had to say it to someone's face, they were a lot more careful about what they said. They were having that empathy and able to kind of do that. And so we've seen definitely a difference in that, which has led to a rise in this like social anxiety because sometimes whatever's said online, they take that as this is the end all be all, this is the truth, and they take that and then it bleeds over into their relationships in person. So with this case study, we will just call her Stephanie. This was a 12-year-old female that I worked with in a middle school setting. She was a 6th grade student, so coming into the middle school, as a new student, she was also new to the district. And so that was another thing that was going on. She was the youngest of 3 with 2 older brothers who were very much, did not struggle with any kind of social issues at all. They were very outgoing, very involved. And so this was a new situation for her parents, even though she was their 3rd child, they were not sure how to address it because their boys had not struggled with this. And so that was a new thing as well. Again, I said it was her first year of middle school. Her parents were reporting, when I met with the parents. So the way that I did things is whereas school counselors kind of they kind of are there for all students for any needs that come up. I was more of a referral base. So I was an intervention counselor. And so I was more of a referral base. And so parents would contact the school counselor usually, or school counselors would start to see students in their office as a revolving door. And so sometimes when that would happen, then the student would be referred to me. And so when I was talking to mom the first time, she was kind of reporting that it was difficult to get her out of the car once they got to school. So even before they would get to that point, she would have a lot of resistance about going to school. She was throwing up every single morning before school because she was so anxious about coming. She was having a really hard time just being in any kind of situation where there was a lot of people around. So she really wanted to be involved. But anytime she was in athletics or band, when there was a lot of people around, the cafeteria was a big trigger. She would have a lot of anxiety around that time and it was triggering lots of panic attacks. And so we were having all of these issues before school. When she would get to school, she wouldn't get out of the car. So mom's stuck in the drop-off line or having to try to get her out. That became a big problem. Teachers started reporting like she would just kind of shut down in class. So she didn't have big behaviors in class, but they would notice she would just kind of freeze or she would shut down. And so teachers were coming to me as well, kind of saying, we're noticing these things. She reported to her parents and to me also that she was eating lunch in the bathroom. So it was so anxiety provoking for her to be with others in the lunchroom because she didn't know where to sit or who to sit with. She didn't want to sit by herself. She felt like everyone was looking at her if she sat by herself. So she was actually eating in the bathroom when I started working with her. And she was also around those times, parents were noticing that around the time that she would have to go to lunch or athletics or band, that she was texting her parents and saying, all of the things about, I want to come home, I'm sick, I'm not feeling well, which, in reality, we know she probably wasn't feeling well, but it was anxiety related and it wasn't actual physical thing going on with her. So some of the parents' goals, obviously, they wanted her to reduce that anxiety before school so that not only so she wasn't throwing up every morning before school, but also so that she would get out of the car willingly. Parents had to go to work. And so that became a really stressful situation for the whole family because she would dread it, parents would dread it. It would end up in kind of an explosion in the car because they're trying to get her out so they can make it to work. And she's getting frustrated and she's getting upset. So they also wanted her to be able to make those connections. So they recognized pretty early on that this was a much bigger issue than just being new to school and having to make friends, but she was actually becoming so anxious about being able to connect with others, being able in social situations that it was physically affecting her as well. And they wanted her to learn ways to stop avoiding those things. So we know a lot of times with any kind of anxiety disorder that kids are going to try to avoid as much as possible. And so parents recognize this isn't going to ever help her learn how to effectively cope with this if we just let her kind of escape everything. And so they wanted her to be able to do that, but also have ways to cope with her anxiety in those situations. As far as when I met with her, she also recognized, part of that DSM criteria is recognizing that her fears were excessive, and that were causing her distress. She definitely had that situation happening. And so she wanted to learn ways to cope with her anxiety. She didn't want this to be something that was going on repeatedly for her. And so, oops, the wrong way. Oh, let me go back. Sorry about that. Okay. So she wanted to be able to make connections. Obviously, as with most kids her age, she wanted to be socially connected. She wanted to have relationships with others. She wanted to be able to kind of, build those connections with others so that she wouldn't feel so overwhelmed. A lot of times with kids that are experiencing social anxiety, if we can get them to a place where they find like their people, they find their friends, then that sometimes is helpful for them to kind of mitigate some of those factors of anxiety. Also with her, she wanted to branch out and try new activities without feeling so much social anxiety. And so a lot of times these new behaviors like being in band or being in athletics, those were new things for her. And she really wanted to pursue those and she wanted to do it, but it was causing her so much anxiety in the process that she was almost ready to quit and just say, you know what, I don't even want to do this because it's just causing me too much trouble. And so some of the ways that I supported her with this. So again, it looks a little different in a school setting. We're not looking at necessarily treatment in the same way we would clinically outside of school. She had actually, before I started working with her at her past school, she had been working with an outside counselor. And mom kind of reported that it was helpful in some ways, but when it would happen, like they would work on a lot of skills, she would learn a lot of things, and then in the moment, she would kind of go into that panic freeze mode, and she would forget everything that they learned. And so they were, they had just moved again, and so they hadn't yet gotten her in with an outside counselor in our area, and so we kind of started with me working with her. And so there was kind of 4 different ways that I worked with her in this situation. So again, providing a support in a safe place at school. So we had to work through where can you come when you are feeling like on the verge of a panic attack? Where can you go if you're having a really hard time with what's going on? And so we kind of talked through some of those things, and I'll go through each of these things about how we did this. We also worked with her. I worked with her on challenging her negative thought patterns. So a lot of times I work with teenagers a lot. And one of the things I tell them is your feelings are always valid, but they're not always true, right? So the thing that comes into your head that you think is just truth in that moment, a lot of times is not truth. It's just how you're feeling. And so when we could kind of work through some of those things, what were the thoughts that she was having that was leading to her feeling this really intense social anxiety? I also worked with her on obviously learning coping skills. So you'll notice through this, when I talk through what we did, there was a lot of support from me up front and kind of walking her through things. But by the end, kind of lessening that support so that by the end of the year, she was doing a lot of this on her own. So I wanted to really equip her with those coping skills so she knew what to do in those moments when she was in those situations. Here's what you can do when you're feeling this level of anxiety. And then I also involved her in a social skills group with some other students. That I was able to identify that were also struggling with maybe not as severe as social anxiety as her, but just like some of those symptoms of having some of those things going on in ways that they could kind of talk with each other. They could kind of get that feedback from each other and feel like she wasn't the only one that was struggling with this issue. So as far as providing this support and safe place at school, so there's a couple of things that I did with her. So again, we talked about in the morning, it was really hard for her to get out of the car because the process was they would get out of the car, she would come in, and she would have to go either into the cafeteria or into the pods, which are like big areas where there's lots of students around. And so that was very anxiety provoking for her. And so what we started doing was that she would come down to the counseling office when she came to school. So instead of going into one of those big areas, she would come down to the counseling office with either me or the school counselor, because I wasn't at her school every day. And so most days I was, and so it would usually be me, but sometimes it would be the school counselor. But we also had where she knew that if we weren't down there, because sometimes things happen and we're not always down there was a counseling suite, like a lobby area that we had where she could sit, and there were some things that she could do to help herself calm down. So just kind of having that transition of being able to get out of the car and come to a quiet place and kind of center herself and kind of calm down before going into the big school day was really helpful. Obviously, we phased this out. We worked on phasing this out till it was no longer needed. So a lot in the beginning of the school year, this happened a lot. Like almost every day she was coming down. But really what we found is if we could get ahead of things and help her kind of do these calming breaks, kind of get herself together before she had to go in those situations, she was able to last longer throughout the day without getting anxious than she was when we just kind of threw her in and she had to go straight to those situations. She also would do calming breaks during the day. So sometimes right before band or athletics or those really intense times for her, she would come down. Again, sometimes it would be in my office. I had a little calming area in my office where she could just kind of sit and calm down. Sometimes she wanted to talk, sometimes she didn't. Sometimes she sat in that lobby if we were with other students and we weren't available. She would just sit down there, but we kind of had this process of how she would do that. We also met weekly. She and I did just to process through her anxiety. This is where we talked about challenging those negative thoughts, implementing her coping skills, things like that. So we were meeting weekly at school. And then we also provided her with a special pass. So she had a pass. We obviously had parent consent and to talk to teachers about kind of what was going on in a very minimal way, but just saying, she would want to come down a lot of times when she felt like she was about to have a panic attack, but she also didn't want to get up in front of the class and talk to the teacher where students could hear. That was very anxiety provoking for her. And so we had a pass that she would use and she would just walk up to the teacher and hand it to the teacher and then she could go. So we kind of had this understanding that she could come and go as she needed to. Again, she was not a student that was abusing that and coming all of the time. It was really when she really, really needed it. And again, if we would allow her to do that throughout the year, we kind of tapered that off as well. So as far as like challenging her negative thought patterns, again, kind of reminding her that her thoughts and her feelings are not necessarily facts, right? So I worked with her a lot on, are you jumping to conclusions? So one of her thoughts was, when I walk in the cafeteria, everyone's looking at me. Like, I know that everyone is staring at me. And I was like, do you really think that's the case? Because at your age, a lot of times everyone's focused on me, right? They're not really focused as much on you as you think. And so kind of looking at things in a different way. Or she would say, I saw this friend in the hallway or this kid in the hallway and they gave me this really mean look. I know that they hate me and now I can't go to that class because I sit next to that student in class. And so when we would really unpack it and talk through it, really, I was like, well, maybe that student's just having a bad day. Or maybe he's about to go take a test and he's really nervous about it. And that's the face that you saw. It really maybe had nothing to do with you. And so kind of just like working with her about, okay, tell me your thought process. Tell me what's making you think these things. And so we would kind of talk through it. And when I would kind of give her the flip side of it is like, okay, well, like, what do you think this could also be? Could it also be this? And she was like, well, maybe. And so just kind of, again, this was a long process of kind of changing some of those negative thought patterns, but kind of getting her to look at that. And sometimes what we did a lot too was, especially once we got to the social skills group, was like having them talk to each other about like, what would you say to a friend in this situation? And I would notice that when one of the students would share something, the other one would jump in and say, well, maybe it's this. And so they would start using some of these things that we were working on with each other. And so that was really powerful to do that. So this was another kind of a worksheet. I know it's hard to see on here. You guys will get these slides, and so you can kind of see the way that we did this. But this is from a book called Rewire Your Anxious Brain for Teens. And so there have a lot of worksheets in there that you can use with students. This is kind of the example, not her example, but a different one. So looking at like actually walking through her thought process. So the first one talks about ways I focus on the negative. So in this example, it says thinking over and over about how my friends don't really like me. They're just being nice. So this was the thought that this person was having in this example. And so we would talk about how does that affect your life in that situation? Shutting down, not wanting to be around people, feeling bad for myself. And then looking at how would your life change if you challenged this thought? So if that really wasn't what was happening, maybe your friends really actually do like you and want to be around you. Then in that way, you would socialize more, you would spend more time with your friends, engage in life more. And then we would also identify the hotspots. So this was places or people who would likely trigger this. So obviously social media is a big one, right? If you're looking at anxiety in teens, like if they're posting this, this means this. Well, maybe sometimes like scaling back some of our social media usage, right? Summertime, so when she would feel a little more isolated from friends and see them doing all of these things, summertime was a big trigger, or with certain people. So helping her identify, are there certain people or certain situations that are going to be hotspots for you. So not necessarily to avoid those things, because we didn't want to avoid that, but how do you need to prepare yourself if you're going into those situations? And so we kind of worked through this on the side, kind of looking at those negative biases that she had, how it was affecting her, and how it would be different if we could change kind of those thought processes. As far as coping skills, so I always, with any child or teen that I work with, I want to give them actual skills they can use. And we all know that what works for one doesn't necessarily work for another. And so I try to go over like lots of different coping strategies that they could use and have them pick like their top three. And obviously some of them you're going to be able to do in certain settings and some you're not. And so I like to have them to have more than one coping strategy that they can use, so that they can tailor it to the situation that they're in, the environment they're in, things like that. So each one of these, I have this in a chart too that you can use with students as well, or with clients. So as far as activities, so do something. We would talk to clients about doing something. So exercising, being with other people, go to eat, watch your favorite movie. Actually, like if you're sitting, I talk a lot with teens about if you're sitting and you're idle and you're just thinking, then things are going to seem a lot worse. So get up and do something. Go do something that you can, that keeps you active, that keeps your mind engaged, that distracts you from what's going on. Contributing. I know that we talked about this earlier, but doing something to help someone else, text someone to check in on them, listen to a friend, call a friend and listen to their problems, doing something that's going to take you outside of your own situation and do something for someone else. Go help your parent out, go help a friend out, things like that. Comparison in terms of thinking about a time when things were worse and recognizing how much better they are now. So a lot of times, especially as a teenager, I think you think that the situation you're in is never going to end, right? This is my life forever. It's never going to get better. You get so swallowed up in all of that. And so kind of having them think about, is there ever a tough time that you went through before? And they'll tell you about that and say, okay, well, where are you now? Is that something you still struggle with? Well, no, it's not. Okay, so that means that probably this situation can get better too if we just learn how to work through it. Breathing relaxation obviously is a really good thing. We all know tons of strategies with that. I think, square breathing, grounding, all of those different things, the progressive muscle relaxation, anything they can do in the moment to actually calm their body down, get their blood pressure under control, their breathing under control, actual physical things they can do in the moment. Opposite emotions is one I like a lot with teenagers. So I have so many kids that sometimes will be like, I'm like so sad today. And so I'm just going to go home and listen to this really sad music and hide myself in a really dark room and, which we know is going to probably make that mood worse, right? And so I'll tell them to do the opposite. So if you are feeling really sad, go watch a funny movie, or listen to a really upbeat song. If you're feeling really like angry, then listen to some calming music or like something that's going to calm you down. So whatever you're feeling, kind of doing the opposite of that or engaging in an activity that's the opposite of that. Pushing away. So this is a lot of times I will do this with teens and tell them, or children as well, to say, put a timer on your worry. So I want you to go set a timer and you're going to get to worry about this thing for 10 minutes. And then when the timer goes off, you got to switch gears. Like we're going to move past that, or turning down the volume on the problem. So sometimes it'll feel so loud in their heads, right? That's all they can focus on. That's all they can hear in their heads. And so just focusing on like, just turn it down and let's, you have a time and a place for this, but then we're going to move past it. We're not going to stay stuck in that feeling. As far as thoughts, like how many, song lyrics do kids these days know, right? Like, so fill your brains, think about your favorite song and like recite those lyrics in your head. Imagine redecorating your room. That's a big thing with teens. I feel like they always want to change their room. And so what would you do? And, start thinking about that, making a list of what you want to do, making a list of what you have to do the rest of the day. Anything you can do to kind of fill your brain. Because again, the more that you're sitting and thinking and focusing on that anxious thought, the more it's going to keep coming up. And then sensations as well. So holding an ice cube until it melts. We know how that is. It feels really cold at first and it kind of starts to hurt and then it melts. If they're at home, taking a hot bath or a cold shower, running up and down stairs, chewing gum, anything like that. If they can get outside, if they're inside, we know sometimes these things aren't possible at school, but sometimes we would have with the ice cube, we didn't have ice cubes at school, but we had like a cold pack at the nurse. And so they would go and put that on their neck or, just different things like that. Just any kind of sensation that kind of shocks you out of that. I think it was our first presenter today that talked about the rubber band thing. Sometimes kids would do that to kind of just a sensation or something that they would do to kind of get them out of that mode. And then when we did the social skills group, so there was like 5 or 6 girls in this group that were kind of in different places as far as dealing with social anxiety. So some of them I had already worked with and we had made a lot of progress. So I had some of those girls in there. Some were kind of at the state where she was at and kind of all in between. And so I allowed them a lot. This was that handout over there was what we went over every time. We would kind of like recite this almost like our mantra for this group of just talking through these things. These were things I encouraged them to take this and put it somewhere they would see it all the time. Take a picture on your phone, keep it on your lock screen, whatever you have to do where you could see this all the time and remind yourself of these things. Because I think some of them are really helpful. That your thoughts and emotions aren't facts, that I can feel anxious, but I can handle this. I've survived tough things, like just kind of reminding them, like, okay, I'm going to be okay. Like if I wasn't there in the moment, then this was something they could look at to remind themselves. And it was really cool to see how they, and kind of like I said earlier, they would really start to talk with each other and normalize it for each other. Like, yeah, I feel that way too. Like, oh, I totally feel that way. I know exactly what you're talking about. So they were able to kind of normalize it for each other, really support each other through that. And then it was really cool to see them start to help each other through it. So they were saying like, yeah, this was something I really dealt with, and here's what I did. And so a lot of times I ended up just sitting back and listening. I would guide it, of course, and if it, got off topic or things like that. But a lot of times when we started, I was doing a lot of kind of teaching and working with them, but then I kind of stepped back and they just kind of took over. And it was really cool to see them really help each other through it. So we did learn the coping skills. We would go over those and kind of talk about things that work for some of them. They would be able to share, this is what works for me, or this is what works for me. And it was a little bit different for all of them. And then we were also able, a really cool part of it was each grade had lunch all at the same time. So 6th grade is at one time, 7th grade is one time, 8th grade was another time. So we were able to arrange like for them to sit together at lunch. And so this really helped her because she felt like she had a table to go to, she had people to sit with. That really minimized a lot of her social anxiety at lunchtime. And so that was just kind of a neat benefit from this, is that they all arranged to sit together. That wasn't even my doing, that was their doing. So that was a really cool thing. And we did talk a lot about social media and setting healthy boundaries with that. I think that's important with any teenager nowadays, but I think it was really important for them because a lot of this social anxiety was, and them feeling like everyone was thinking about them or looking at them or concerned with them, had a lot to do with their social media usage and things like that. With her, again, a lot of these things, and it sounds like, I know probably some of the school counselors are like, how did you have time to do this? Or how would we ever have time to do all of this? I will say this was over a year-long period. There were things we did at certain times. And again, kind of that scaffolding, I gave a lot of support up front and we did a lot of things up front. And by the end of the year, I was hardly even seeing her. And so it was really, we felt like if we could meet these needs now, we could get her comfortable and we could get her to learn some of these skills that she could use and then kind of get her out into situations, she was able to kind of do that. So she was able to connect with those students, not just the students in the group, but some other students as well, and kind of get to feel more comfortable. She wasn't automatically avoiding things. There was still, of course, anxiety anytime she would go into those certain settings. But she was able to really kind of work through it and she felt more equipped to handle it than just going in blind by herself. Those morning transitions became a lot easier. So once she made those connections, she started to feel more connected with other kids. She was coming less and less to do check-ins with me and more going down to the pod or the cafeteria to like sit with her friends instead of needing to come to me. And that made the transitions for parents a lot easier because she wasn't having so much anxiety in the morning before school. She wasn't refusing to get out of the car when she got there. It became by the end of the year, she was able to get out and go into the building and just go on with her day. So we were able to phase out a lot of those morning check-ins, the calm down times by the end of the school year. And I will tell you, when she came back in 7th grade, it was like, I only saw her if I called her down. Like it was like night and day difference with her. She was able to figure out a lot of those coping strategies that worked for her. And then at the end of this year also, I did refer her out to get in with an outside counselor so that once we worked through some of these things in the school setting, then she transitioned to a therapist outside of school to really continue the work and continue working on her anxiety and learning different things as well. So we helped her with those coping strategies. And then she actually reported, it's hard to measure things sometimes in a school setting, but she reported just feeling a lot of success in managing her thoughts, definite reduction in the panic attacks. I saw it through obviously her not coming down as much and not feeling like she needed to come down as often. And so parents reported differences. And so just all the things that we did, just seeing across the board, like a huge progress with her. So it was really, really neat to see that with her. So, all right, so there's my information. If you guys have any questions at this time.
It looks like that we don't have any questions that are coming in, but we're going to stay on. Becky, thank you so much for sharing. I think that this is, I know when I worked in schools was a big challenge, so I appreciate all the walkthrough of the case example, and thank you so much for your time. So let me share my screen real quick, and we will move into uh, the evaluation. Okay, so I'm putting up on the screen right now the link to do the evaluation. I'll also add the link into the chat box. If you could please just take a few moments to fill this out, and after you get done completing the evaluation, you will be sent at the very end. You can either print your certificate or you can make sure you hit submit and it will be emailed to you. We do have another one of these wellness workshops that will be coming up in November, and it will be over ADHD. So be looking for that. That will also come in a follow-up email once we post the video of this workshop with the link to sign up for the next one. So we'd love to have you guys come to that one. And we will just stay on here. If there's any other further questions, feel free to put them in the chat box, or you can put them in the Q&A, and we'll stay on here for any last minute questions and to give everyone a chance to finish the evaluation. I also just want to take one last minute to really thank all of our speakers for sharing their expertise and their time with us. I think the information that we heard today was so valuable and helpful. So thank you.